Okay, we'll call the Health and Human Services Committee back to order, and we'll continue our discussion on HF 3202. I believe at this time, Representative Liebling, you had a question.
Right, Mr. Chair, thank you very much. And I know that since this morning, there's been all kinds of speculation about what this question was going to be. People told me I better make it a good one. But actually...
We're sitting at the edge of our chair.
I know. So we heard from this morning a lot about this issue, and we heard from proponents of the bill and opponents of the bill, at least from St. Joseph's Hospital, people opposing it. This is an issue that is really difficult for members to decide. Representative Schomacker, I think there's a very good reason why we have the process we have, where the Department of Health kind of gives us the lay of the land on these moratorium issues. I mean, I've seen them before, and they are often difficult. And the problem that we have is that if we vote on this bill tonight, we don't have complete information. I mean, I don't know about other members, but I feel like there's a lot missing here for me. Because, you know, there are lobbyists, there's a lot of lobbying around this issue. Obviously, there's a lot at stake for these hospitals, but there's also a lot at stake for the people of Minnesota. There's a lot at stake for people who live in St. Paul in particular. And we all need to make the best possible decision. And I know that the chair or Representative Schomacker had mentioned earlier something about this going to conference committee and being decided there. And so the question I really have is to Representative Schomacker kind of what you are planning for the path of this bill, given sort of that we've learned how complicated this is. And I know that it started out seeming a lot simpler before the opponents showed up. And so that's what my question is. It's really a question to you about that. And before you answer, let me just say that what we've seen in the last few years is this really troubling tendency to push the decision-making all into conference committees. And I find that really problematic. For one thing, there are fewer people involved, fewer members involved in it. For another thing, it's more out of the public eye. There are fewer opportunities for constituents to weigh in. And I just think that we make better decisions when we make it here in the committee in the light of day, although it isn't the light of day anymore, but at least people aren't asleep for the most part. And, you know, so I'd like to just ask you and try to, you know, prevail upon you to hold the bill here in committee. You can always go through the Rules Committee. There's no problem with that. But I just feel like members need to have that Department of Health information before we can know how to vote on this bill. So I'd like to ask the chair, kind of, Representative Schomacker, what your intention is with this bill.
Chair Schomacker.
Thank you, Mr. Chair and Representative Liebling. The intent is to, just as you had surmised, was to get it to the floor, then bring it to conference committee and wait for the report back from the Department of Health, as well as get some of these, the different interested parties to come to some kind of consensus on some of these things. Make sure that all the lobbyists who have been visiting you are getting paid for doing something around here on some of that stuff. And so the hope originally was to have some kind of consensus amongst the different healthcare systems throughout the metro area before we brought this bill forward. But because of deadlines and because we're still waiting for the Minnesota Department of Health bill, their report, we just couldn't do that anymore and still get this out during the deadline period. And so the intent is to still have all the parties come together to hear from the department, to work towards a consensus from the different interested groups involved, and come back to everyone through the conference committee process.
Mr. Chair.
Evening.
Thank you, Mr. Chair, and thank you for that, Chair Schomacker. You know, I agree with your analysis that we need to have people come together and all of that and have more information, and that's all fine. But until very recently, when you had a bill like that, you parked it in committee, not in a conference committee. Because in the meantime, members have to vote on it, and they have to vote without complete information, particularly if you bring it to the floor. Members are taking a recorded vote. I don't think anybody here tonight is going to ask for a roll call on this bill, but it could happen. And when you get it to the floor, it's a recorded vote, and so you're having members vote on something. Our votes mean something. People look at them. They take something from that. And so to ask members to take a vote on something as consequential as this, without that information, so that the real decision-making can be made in conference committee and then come back where no one can offer an amendment anymore, that's just not the way the process is supposed to work. In terms of deadlines, I think I'm sure, that when you're in the majority and you're a chair of a committee, if your leadership is not opposed, the deadline doesn't mean anything. It'll just go to rules, and then it'll come to the floor when you're ready to have it do that. So, I mean, I really would just ask that you do that, because it would be respectful to members so that we could actually help make the decision on the bill, and not just have essentially be asked, first of all, to vote on something that we don't have complete information on the floor of the House, and then have it come back from conference where we just get an up or down vote and that's it. So, that's just not the good way to make decisions. That's not what our process here is designed for. So, thank you very much.
Chair Schomacker, any comments?
Mr. Chair, at the moment, no. Hopefully there's a little more discussion. I can think about that just a little bit.
Okay, members, any additional questions? Oh, Representative Halverson.
Thank you, Mr. Chair, and I too really would like to see complete information before we vote. If that's not offered to us, perhaps we could talk about coming back and having another full hearing at least, so that we can hear from regarding the department's findings and reactions to that. I think that we all want to be sure that the process is followed and that we have the best information possible when we take this vote, because it's an important issue for the state of Minnesota, the way that we plan for the future of healthcare in Minnesota. So making sure that we have an open dialogue also feels like it's really important. And it's my first year on this committee, and we're all going to be saying goodbye to each other soon because policy deadlines are over. So maybe it'd be nice to come back together and talk about this a little bit further and have a hearing in the open for the public to be a part of when we have all the information.
Okay, final comments, Chair Schomacker? Representative Liebling?
Mr. Chair, thank you. And Chair Schumacher, I think, clearly this is something that would bear a little thought. And so, I would suggest we could simply lay the bill on the table right now, just, or whatever just the temporary thing, and just bring it up again at the end of the evening when you've had a chance maybe to consult whoever or think about it or whatever. That's just another option that would be available.
Final comments, Chair Schumacher?
Yes, Mr. Chair, I'd like to take Representative Liebling's thought on that and take a little bit of time and figure out where we can go from that approach. And so,
You'd like to lay?
yeah, let's just lay it over for now. And
Okay. Okay, so the motion is to lay the bill over. It's laid over. I didn't know I had that authority, but I do.
Mr. Chair, great authority, isn't it?
Yeah. Okay, the next bill on the calendar is HF 338. Representative Johnson moves at HF 338 be re-referred to the Committee on Government Operations and Elections Policy. Right, I moved it.
You earned it.
Oh. Correction, I move HF 338. Representative Johnson is not on the committee, to be referred to the Committee on Government Operations Elections Committee. Representative Johnson, I understand you have an A1 amendment, is an author's amendment. I move the A1 amendment. Representative Johnson, to your amendment.
The amendment is, we believe there might be some appropriations that are needed to in fiscal in 19 and then also in 20 and 21 possibly. And so it's the amendment deals with that issue.
Okay, any discussion on the amendment? Seeing none, all those in favor say aye. Aye. Those opposed, same sign. The amendment passes. Representative Johnson, please give a brief explanation of your bill as amended.
Thank you, Chair and members. House File 3338 is an initiative of the Minnesota Sheriff's Association to authorize the use of low-dose X-ray body scanning devices for the purpose of scanning incoming inmates to local jails for concealed weapons, drugs, communication devices, and other contraband that pose serious risk to the safety and security of jail staff and other inmates. The Minnesota Department of Health regulates X-ray devices used in Minnesota. Current law applies to limit the use of those scanners to medical settings. This bill would authorize the use in the local and state correctional facilities and authorize rulemaking authority for the Department of Health to regulate these devices in addition to those in the medical facilities. With me today is Commander Dave Paschal of the Anoka County Sheriff's Office to give the committee additional testimony.
Welcome to the committee, Officer Packle. Packle, is it?
Yes, sir.
Okay, and please introduce yourself and state your testimony.
My name is David Paschal. I'm a commander with the Anoka County Sheriff's Office. I oversee jail operations. I'm here to petition you to support this effort because we are facing a serious contraband issue in our local jails, workhouses, and correctional facilities. When I started in this line of work about 30 years ago, contraband was a non-issue. It rarely came into our jails, and when it did, it was very unsophisticated. We usually intercepted it before it came in. Unfortunately, that has changed in recent years. We have seen sharp increases in the efforts to smuggle contraband of all sorts into our facilities. This contraband goes directly against our core duty, which is the duty to protect. We have a duty to protect the people that are incarcerated in our facilities. We have a duty to protect the public and the people that work there. The introduction of this contraband goes against that. These low-dose scanners are in use in multiple facilities throughout the country. We are simply looking to introduce them here. We currently have no viable method for finding well-hidden contraband. I mentioned earlier we're seeing a much higher incidence of drugs coming in. We're also seeing increasing sophistication in how they're smuggling the drugs in, and we are also seeing people willing to go to great extent to smuggle the drugs into our facilities. The hardest type of smuggling for us to detect is when they hide the contraband within their bodies. I'm carefully dancing around that topic there, but it is a growing concern. Honestly, I wish I would have had one of these devices in my jail last week because we just came across somebody smuggling in a fairly large amount of drugs into our jail, and we caught it through a combination of good luck and an officer being in the right place at the right time. There was nothing we could have done on the intake to detect the drugs coming in. We went back and reviewed all of our steps. We reviewed the intake. It was done in a textbook manner. It simply would not have discovered something that was hidden inside the body. This bill will give us the tools we need to detect those kind of things and prevent them from coming in the facility. I'm not an expert. All this basically does is give us the same authority to use these devices as they have at the airport where we pass through these body scanners when we fly. And the same body scanner that we're looking at is used in federal facilities already in Minnesota. The Department of Health is partnering with us on this. If there is any need for expert testimony, I will definitely defer to them. But basically, this just gives us the tools we need to better do our job.
Thank you for your testimony. Representative Johnson, do you have any other testifiers?
I do not at this time.
Okay. Is there anyone in the audience who wishes to testify for or with concerns about this bill? Seeing none. Members, any questions or discussion? Representative Liebling.
Thank you, Mr. Chair, and thanks for being here tonight. So, under the bill, how often would an individual get screened? Is this something where they're going to only be screened on the way into the jail, or is it going to be, and I'm asking because this is a health committee, and I'm interested in kind of how often a person is going to be exposed to the radiation.
Officer Patchell.
Mr. Chair, Representative, to get to the finite details of what is a safe dosage, I would rely on our counterparts at the Department of Health. It is our intention anecdotally to use this to screen people when they come into the jail, or if for some reason there's somebody in the jail and we feel that there is a need to check for contraband that's hidden. It would not be done on a daily basis. It would just be done on intake and on a suspicion of contraband.
Do we have someone from the department who might answer Representative Liebling's question? Okay, welcome to the committee. Please introduce yourself, and I think you heard the question.
Good evening. My name is Mary Navarra. I'm a section manager for environmental health at the Department of Health. The X-ray program falls within that section. To answer the question and to refer to what the commander's already said, each one of these facilities and each one of these machines will be working with the Department of Health to make sure that we have safeguards in place. So anytime that there's somebody that is coming through and that there are standards, there are health policies and things that we will ensure that that happens. So we already work with the medical facilities and we ensure that there are radiation safety officers.
Representative Liebling?
Thank you, Mr. Chair, and thank you. Well, that kind of raises some more questions. So radiation safety officer, so is there going to be a radiation safety officer in every facility, jail facility that's going to use this? And then is there going to be, I mean, now I know people may intend to do all kinds of things, but we're passing a law here. So I'm kind of interested in what is going to be in law or in rule that's going to make sure that certain things happen. So how are we going to keep records? How are we going to, who's going to write a policy? Is that going to be a policy for each place? And to make sure that, people coming into jail aren't exposed to excessive radiation, or people who are in jail aren't exposed to excessive radiation? How's that going to happen?
Excellent question. Mr. Chair, Representative Liebling, each one of these facilities will be governed by rules. And in those rules, we do have safety officers, radiation safety officers. And again, those are trained people whose specific job is to track the radiation that people are exposed to.
Representative Liebling?
Okay, thank you, Mr. Chair. So the agency is going to engage in some rulemaking, or maybe there are already rules in place. And then that radiation safety officer is going to be somebody who's already employed by the jail. So each facility is going to designate a person who's going to be responsible. Is that how it works?
Mr. Chair? Yes, there will be somebody who has to be designated, and yes, there will be rulemaking, so it will be very specific as to the controls.
Okay.
Representative Liebling?
All right. Thank you, Mr. Chair. Thank you very much.
Members, any other questions? Seeing none, Representative Johnson, any final comments?
Well, Mr. Chair, members, this is a bill that allows jailers and corrections officers and the inmates not have to go through very invasive and not very fun searches. It's a way to stop a lot of contraband that gets into the jail facilities, which is happening a lot, not only for narcotics, there's weapons, there's communication devices. I was just told earlier about a cell phone that was brought into the jail, into one of the correction facilities, and where this equipment would find those things and stop a lot of those things from happening. I think it's a good bill, and I think it's something that needs to be done for the safety of our corrections officers and also for the safety of our inmates. I ask for your support for this bill.
Okay, thank you, Representative Johnson. I renew my motion that House File 338, as amended, be re-referred to the Committee on Government Operations and Elections Policy. Those in favor of the motion, say aye. Aye. Those opposed, same sign. The motion prevails. And House File 338, as amended, is re-referred to the Committee on Government Operations and Elections Policy.
Thank you.
Thank you. The next bill on the agenda is House File 3626, Representative Bennett. I move House File 3626 be re-referred to the Committee on HHS Finance. Take a moment to get settled there. Are you ready?
I am ready, Mr. Chair.
All right. Representative Bennett, I understand the A1 amendment is an author's amendment. I move the A1 amendment. Representative Bennett, to your amendment.
Thank you, Mr. Chair. The A1 amendment does two things. First of all, the House language, we have cleanup language added to the Senate side, and this House language meets with that. And secondly, we're deleting lines 2.10 and 2.11. And then renumbering things for that. And the reason we're deleting those lines, the goal of this amendment is to remove language that prompted some concern to implications that the language may have with the judiciary branch. The author's intent is for the impact of this bill to assure rights as they are related to best practice, but not to interact with the judicial practice or required oversight. So we are taking those two lines out.
Okay. Members, any discussion on the A1 amendment? Seeing none, I'll call for the vote. All those in favor of the amendment, say aye. Aye. All those opposed, same sign. The amendment passes. And the A1 amendment is adopted. Representative Bennett, please give an explanation of your bill as amended.
All right, and thank you, Mr. Chair and committee members, for hearing this bill. This bill seeks to help children who are among the most vulnerable in our society, and that's our foster kids. And we know how important siblings are to all of us and our own families, and foster kids are no different. When I read through this bill, I thought, boy, this is just common sense right here. And for foster kids, really for siblings, they're probably more important to foster kids than they even are to us. So children in foster care already face difficulties that are tough to imagine, and I think we can help ease these hardships and promote healthy growth by helping these kids stay connected to their siblings as much as possible. So this bill builds upon the wonderful work that our foster parents are already doing. It creates guidelines for close connections for foster siblings when it's in the best interest of each sibling. That includes things like visits, phone calls, and taking part in other important celebrations like birthdays, all the things that we all get to do. So I'm going to actually stop right here just with that brief description of what this bill is, because I do have a couple of testifiers.
Welcome to the committee testifiers, and if you'd like to introduce yourself and, if possible, try to keep your testimony to about 2 minutes.
Okay. My name is Viviana Castillo-Roybal, and I'm a part of the Minnesota Youth Leadership Council. And back in October of 2016, I went to a leadership council in Washington, D.C. Upon going, I realized that there have been other states that have something called the Siblings Bill of Rights, which you're all looking at now. And when I was put in care when I was 13 years old, my brothers were separated from me. I have 2 little boys who had basically been my children since day one. I was already in shock from being taken out of my home, and having them taken away from me was not the greatest experience. For several years, I wasn't able to see them. I maybe saw them twice and got very few phone calls. A lot of it was mostly the foster parents placing it as a punishment because I wasn't the most well-behaved child. They said, because you didn't behave well, you can't see them anymore. I just really want to make it a key point that this is important to me. I know a lot of you don't get to listen to people actually that have lived through it. Like, you don't get to listen to them very much. I just want to be able to see my boys again. I'm 19 years old and it's still hard. I just really want your help with this, and you're my last option that I have. So if you could do that, that'd be great.
Okay, thank you for your testimony, Ms. Castillo-Ravel. And you have another testifier, Representative Bennett?
I do, Mr. Chair.
Please introduce yourself and try to keep your testimony within 2 minutes if possible.
My name is Sasha Omar, and I'm also a part of the Youth Leadership Council with Viviana. I got put in care. I have a younger sister and 2 younger brothers and an older brother. My older brother was too old to be in the care with us, so it was just us younger ones. Over the time, we had court order visits. The foster parent my sister was with basically canceled because of what she had got going on, and that wasn't fair to us. So it really made a big impact on me and my siblings for not seeing our little sister. When she came home to my uncle, our connection wasn't as strong as it was before, and that hurted me, which just hurted her. So I would really like that if, this bill did get passed, it would help a lot of siblings in care with siblings that went through what we went through. So I would greatly appreciate if it went forward.
Thank you for your testimony, and we pray too that the bill helps your situation so that people like yourselves in the future won't have to suffer those types of consequences. Is there anybody in the audience who would like to testify for or with concerns about the bill? Seeing none, members, any discussion? Representative Liebling.
Thanks, Mr. Chair, and just to thank you for coming, and, it's really sad that we even have to pass a law to have this happen. Why people don't understand this without having us tell them? And I'm so sorry that you had to come all the way to here to get anybody to listen to you on this. That should not happen. It just seems so obvious that siblings need each other, and when you have stress and other things going on in your family that you're in foster care, to also take your siblings away from you is just unless it's absolutely necessary, but it just seems absolutely cruel and inhuman. And so, I'm really glad that I hope we can do something about that for you. Thank you.
I don't think that was a question, so Representative Sandstead.
Thank you, Mr. Chair, and this is to the author. A while ago, I used to do respite care / foster care. It's been a few years, and I know that we were restricted to a number of children that we could have into our home at any one time. Is there anything right now that a situation like this would kind of bump up against, where a foster home would be restricted to allow only a limited number of children? In our situation, we had a family of 3, but we could only have 2 children at one time. And I'm just wondering I think this is a great idea. I think it's absolutely common sense. But is there something else that we need to look at to make sure that we can take care of it so it's not a roadblock?
The testifier, Representative Bennett, do you want to respond?
I could respond to that, Mr. Chair. And thank you. That is an excellent question, Representative Sandstead. What this does, we're going to work within the constraints of the system right now. And we know there are limits, like you say, on the number of children foster parents can take in. We have a shortage of foster parents that weighs into things too. What this is guidelines. It starts by saying, if possible, place those siblings together in one home. That may not be possible. So if it's not possible, then it's asking that they would be placed hopefully in close proximity, maybe like the same city or nearby, and also using things like technology, allowing those young people to FaceTime together to call on the phone, to just maintain those contacts, to attend birthday parties and graduations and all the things that we normally get to do with our siblings. So it is taking those constraints in mind. It's not a mandate. It's simply guidelines saying, if possible, do this, because it's important to have those normal experiences. But you're very right. There are constraints that we'll have to work through and do our best within that system.
Representative Stansted?
I just want to say thank you for bringing this forward. I think this is really a great piece of legislation that can help reduce the trauma in what is already a traumatic situation. So thank you.
Representative Helverson?
Thank you, Mr. Chair. I just wanted to say to the author and the testifiers, well done. You've been here and seen your words have a lot of action, a lot of impact, and our job is to listen and to serve you. So if this becomes law, which I hope it does, I hope that you give us feedback on how it works and how we can keep making it better, because you clearly have a vision on the best way that we can make sure that families can be together and you can have those family relationships. Siblings are important and siblings are special. And being the oldest sibling, you have a real responsibility, I know, in your heart. I didn't even like to go on my band trip when I was in high school because I didn't want to be away from my little brother and sister. So I know that feeling, and you have a lot of power. I just want to affirm that for you, that you coming here and telling your story and asking for this, you're making a big difference. So thanks for doing that.
Okay, Representative Bennett? Oh, Representative Olson, I'm sorry.
Thank you, Mr. Chair. Echoing everything everybody said, I thank you, Representative Bennett, for bringing this forward. Really good bill. I had 6 youth from my district come down, youth leaders, and tell me their stories that were really powerful. So thank you for that. My question is, or just a comment/question is, this is really good, and I think especially some of the language around the consequences for behavior and some really good things that the youth themselves have said would impact. Thinking about how great we put it in law, let's go forward, let's do it. Thinking about enforcement, and if you've put any thought into, it's great, it's on the books, but how do we make sure that happens? And maybe that's a conversation we need to have again after, but I'd love to just hear a little comment around how do we make sure this actually happens? So comment around enforcement would be, question/comment.
Representative Bennett?
Yeah, I'll be glad to comment on that, and I'm not sure if my testifiers want to also. Again, this is guidelines, so it's not going to be a mandate saying you have to do this. One thing it does is it places this foster sibling Bill of Rights into the hands of every foster child so that they know their rights too. That's important, and gives them information on connecting with an ombudsman, if I got that pronounced correctly, and that type of thing, and would also just educate foster parents and basically our foster system. So that's going to be the job of the agency to disseminate this information, and they are behind this too. So I'm confident that they're going to get that information out. We may have to deal with it later, but I really think that once this information is out, like Representative Liebling said, it's just plain what should be done. It should have been done before, and I think everybody who sees it believes that. So I guess I'll figure the system will handle that well, and we'll move forward and help these young people stay connected to their siblings.
Representative Olson? Okay. With that, Representative Bennett, do you have any final comments?
Thank you, Mr. Chair and committee members. I appreciate your supportive words and look forward to moving this on and getting these things done for our foster children. So thank you, and you guys.
Thank you, and thank you for your testimony and highlighting this issue, which hopefully can help other young people found in a similar situation. I renew my motion that House File 3626 as amended be re-referred to the Committee on HHS Finance. Those in favor, say aye. Aye. Those opposed, same sign. The motion prevails. And HF 3626 as amended is re-referred to the Committee on HHS Finance. The next bill on the calendar is HF 3857, Representative Kiel. Representative Kiel moves HF 3857 to be re-referred to the Committee on HHS Finance. When you're ready, Representative Kiel, please give a brief explanation of your bill.
Thank you, Mr. Chair and members. As you know, I've been coming forward with different bills about the discussion about the OHFC, or the Office of Health Facility Complaints. This bill deals with investigations requiring quarterly reports and a yearly report after 2021. That seems like a long ways off, but it'll be here tomorrow. So anyway, but more importantly, with the Office of Legislative Auditor recommendations, that we have assessments, that the legislature does know what's going on, and that we hear that reports are being answered. The first, it doesn't say in here, but in the 3308, it does refer to at least 2 reports before or by January 2019, and then, and of course, then the yearly in 2021, so that we know what's going on. With that, I don't know if members have questions regarding this House file, but
Representative Kiel, do you have any testifiers?
I do not.
Okay. Is there anyone in the audience who wishes to testify for or with concerns about this bill? Seeing none, member questions. Representative Olson?
Thank you, Mr. Chair, and thank you, Representative Kiel, for all you're doing and bringing forward. Just more of a comment. I think it's great that we have focused a lot of time on the Office of the OHFC. I think we need to do that, and I just hope that, in the continuous improvement we absolutely need, and I hope we also, spend as much time and attention and effort on really looking at, again, where the source, where these complaints even originate, and we really try to have continuous improvements on that end as well as after the wrongdoing has occurred too. So thank you.
I don't think there was a question there.
No, comment.
Okay. All right. Any other member questions? Seeing none, any final comments, Representative Kiel?
Mr. Chair and members, this is the part of transparency that we are trying to address with this. So remember that. This is just part of this, and making sure that we always know what's going on and that it isn't out of our viewpoint, and being responsible for the oversight of the OHFC is the intent. So with that, I hope you support the bill.
Thank you, Representative Kiel. Representative Kiel renews her motion that HF 3857 be re-referred to the Committee on HHS Finance. Those in favor of the motion say aye. Aye. Those opposed, same sign. The motion prevails. And HF 3857 is re-referred to the Committee on HHS Finance. The next bill on the agenda is HF 3689. Representative Kiel moves HF 3689 to be re-referred to the Committee on Civil Law and Data Practices Policy. Representative Kiel, please give a brief explanation of your bill when you are ready.
Thank you, Mr. Chair and members. The department came to my office and asked if we could consider this bill, which helps us to identify stillbirths and what is happening with them. And with that today, I have with me, I'm going to try this, Barb Fronert. Fronert?
Yes.
There we go. And she's going to fill you in.
Welcome to the committee, Ms. Fromet, and please introduce yourself and try to keep your testimony within 2 minutes if possible.
Good evening. My name is Barbara Fronert. I'm the supervisor of the Birth Defects Program at the Minnesota Department of Health. This legislation expands the Minnesota statute for the birth defects information system to include birth defects that result in a stillbirth, which is also known as a fetal death. The proposal also clarifies wording to ensure that the protections of the statute apply to all parents and legal guardians, regardless of whether the child was born alive or was stillborn. The Birth Defects Information System statute was enacted in 2004, and it monitors trends in birth defects, detecting emerging health concerns, identifying affected populations, and most importantly, connects families to appropriate resources. The BDIS started in 2005 with babies born in 2 counties and has since expanded statewide. To date, birth defects are identified among live births only. This leads to a significant underestimation of the number of Minnesota pregnancies that are affected by a birth defect. This has become of more concern with the recent spread of the Zika virus and the increase in birth defects among exposed pregnancies, including microcephaly. Serious birth defects increase the risk of stillbirth, and Zika is also linked to an increase in miscarriage and stillbirth. Nationally, most birth defects programs include stillbirths in their information systems, and this provides them with a more accurate understanding of the impact of birth defects to families and the communities where they live. This bill has been supported by the Stillbirth Advisory Work Group, which has met over the past 2 years, and it is one of the recommendations to expand BDIS to include stillbirths. The bill is also supported by the March of Dimes. Pregnancy loss is more common for other conditions too, including trisomy 18 and anencephaly, and we've looked to see that we estimate that we're probably missing about half of the cases of anencephaly because we're only looking at live births. This anencephaly is frequently preventable, and without identifying all the cases, we basically miss that opportunity to try and reduce a recurrence of the same condition in a future pregnancy. So this does affect our ability to target outreach and prevention efforts. Without including stillbirths in the birth defect surveillance system, Minnesota does not have a complete picture of the problem and may be unable to identify what changes are necessary to prevent birth defects in the future.
Well, thank you for your testimony, Ms. Fronert. And do you have any other testifiers, Representative Kiel? Okay, is there anyone in the audience who would wish to testify for or with concerns about this bill?
We did
Okay.
have another testifier.
Please come forward and introduce yourself and try to keep your testimony within 2 minutes if possible.
Mr. Chair, good evening, and thank you for allowing me the time to speak tonight. My name is Lindsay Wimmer. I'm the Executive Director of Star Legacy Foundation, which is a national nonprofit based in Eden Prairie that's dedicated to stillbirth research and education. I'm also here tonight as a pediatric nurse practitioner and the mother of a stillborn baby, so this issue touches my heart on many levels. Our organization represents thousands of people like me, health professionals, researchers, stillbirth families, and advocates. And we understand that there are many, many babies that are affected by these birth anomalies that aren't able to survive their delivery or even the pregnancy itself. But yet much can be learned from their situations. We actually would like all stillbirths to be reviewed and monitored in a similar manner, but the proposed changes could create significant opportunities to learn more about how to care for living children with these conditions, better care for similar pregnancies in the future, and then prevent future deaths and injuries as well. So I thank you for your time and consideration.
Thank you for your testimony, Ms. Wimmer. Is there anyone else in the audience who wants to testify for or with concerns about this bill? Seeing none, members, any discussion? Representative Halverson.
Thank you, Mr. Chair, and I'm going to admit this is off topic, but our testifier from the department said something so interesting I wanted to follow up. And when you mentioned that anencephaly is preventable, I hadn't heard that before, and I'm just curious if you can just really briefly mention what preventative efforts are out there to prevent this defect.
Ms. Fronert.
Now is my opportunity to encourage all women of childbearing age to make sure that they are taking a sufficient dose of folic acid on a daily basis, regardless of whether they're intending to have a pregnancy or not. Women that have had an NTD-affected pregnancy are many times more likely to have another pregnancy affected by an NTD. It's also, an NTD is when your spine and brain doesn't form correctly. And anencephaly is the most severe kind. Spina bifida is more common, and one you hear about a little bit more often. If women who have had a prior pregnancy take 4 micrograms of folic acid daily before pregnancy, their risk of having another pregnancy is greatly reduced. Not all NTDs are folate, are related to folate, but many of them are. They think that 50 to 70% of neural tube defects could be prevented if women had enough folic acid prior to becoming pregnant.
Representative Halverson.
Thank you, Mr. Chair. That was interesting.
Chair Dean.
That was my question.
Okay, do you want to repeat that, Ms. Fronert? No. Okay.
The message is, take your folic acid.
Take your folic acid. Members, any other discussion? Seeing none, Representative Kiel, final comments?
I just hope that everyone will support this bill.
Thank you, Representative Kiel. Representative Kiel renews her motion that HF 3689 be re-referred to the Committee on Civil Law and Data Practices Policy. Those in favor, say aye. Aye. Those opposed, same sign. The motion prevails. And HF 3689 is re-referred to the Committee on Civil Law and Data Practices Policy. The next bill on the agenda tonight is HF 3398. The bill, I move HF 3398. I better start using my glasses. I can't see anymore. I move HF 3398 be referred to the Committee on Civil Law and Data Practices. Representative Zerwas, please give a brief explanation of your bill when you're ready.
Thank you, Mr. Chair and members. House File 3398 is dealing with the sunset on the all-payer claims database. Reports using the Minnesota APCD data have been critically important for the legislature in recent years. There is just no other data for us to learn the kind of critical things that we've learned the last 3 years about the burden of chronic disease in Minnesota, differences in service across the state, and efficiency of healthcare delivery. Without that data, we would not know about the extent of differences in prescribing antipsychotics for children, how much we spend on a set of low-value services that don't offer as much help for patient outcomes, how often patients go to the hospital or emergency department when it could have been avoided, and many others. This bill does not create new or additional authority for the Department of Health. It just allows them to continue doing the same work that they've been doing to bring these issues to light, helping the legislature and others understand why costs are increasing so that we can develop and evaluate healthcare reform strategies. The bill does not change the data that's collected. No new data elements are being added, and there is no new cost for the Department of Health or data submitters. It does not change anything about how patient data is shared between providers. There is no connection between this bill and previous discussions around the Health Records Act. The data, just for everyone's recollection, the data that we're talking about is de-identified and de-linked data. The state, while it uses this data, never has anyone's name, never has anyone's address, social security number, or any other identifiable information. With this change, the same restrictions will apply related to the MDH not being allowed to publish information that identifies patients or providers. And with that, Mr. Chair, I think there might be a testifier or two, and then I'll be ready for some questions.
Yeah, Representative Zerwas, do you have any testifiers on your bill?
I have, the department is available for answering questions.
Okay. With that, is there anyone in the audience that would like to testify for or with concerns about this bill? Please come forward and introduce yourself and try to keep your testimony to 2 minutes if possible.
Thank you, Mr. Chair, members of the committee. I have talked with, I'm Twyla Braze, President of Citizens Council for Health Freedom, and I have talked with Representative Zerwas about my concerns. And I appreciate the opportunity to testify, and so I just give you some information about the all-payer claims database for those who may not understand what it is. First of all, by the end of 2013, the Minnesota all-payer claims database contained 872 million medical claims, 4.3 million unique lives, and 89% of insured Minnesotans. That was nearly 5 years ago. Today, this database of information on Minnesotans is much larger. In 2010, there were only 32 data submitters, but with the state pushing employers to comply, there were 105 data submitters in 2014. According to a 2011 report found on the All Payer Claims Database Council website. The reported annual state funding ranges from $350,000 to establish a bare bones data system to $1 million to $2 million to establish a data system. These numbers are for states ranging from approximately 1.3 million to 5.5 million lives. So we have several questions. One is how much are Minnesota taxpayers paying to fund this government data collection and analytics system? How much for MDH staff? How much for the on-point contract in the state of Maine? And what is the unfunded cost to health plans and third-party administrators and their enrollees and clients to submit the data? And there is a cost. You may know that Liberty Mutual sued the Vermont government for its demand that their ERISA-protected plans third-party administrators submit claims data on their employees to the Vermont All-Payer Claims Database. According to Cornell Law School, Blue Cross and Blue Shield said it required additional full-time employees and hundreds of additional employee hours and communication with state regulators. The U.S. Supreme Court ruled in March 2016 that Liberty Mutual was not required to share the data because of ERISA protection. In 2016, the Minnesota Department of Health testified before a conference committee that they were looking at the legal implications of the Supreme Court ruling. So one question is, have they notified ERISA-protected companies in and outside of Minnesota that data submission is not required? This has been a controversial database, yet this bill seeks perpetual use of patient encounter and pricing data for the purposes listed in paragraph A3. Perhaps the legislature should request an audit of this unfunded mandate instead, including the cost of reporting, as well as the cost of data storage, data transmission, encryption, health department researchers, analysis, department publications, and the on-point contract. According to our research, only 16 states have all-payer claims databases in operations. 2 others have it on the book but not implemented. The Minnesota Department of Health says it was one of the first adopters of this database and that it collects information from Medicaid and Medicare as well as commercial payers and self-insured employers, those who are protected by ERISA. The only ones protected from state scrutiny of their care are those who pay cash. Now, you have heard that that the information is de-identified. But de-identified data can and has been re-identified, and in this day and age, even anonymized DNA has been re-identified. According to the HHS Department standards for de-identification, it is all still identifiable data. Furthermore, data is power. He who holds the data makes the rules. It's impossible for anyone without the same level of access to the data to refute the department's claims about what the data supposedly says. And these claims can be used to push government policy agendas that the subjects of the data oppose. This is a large, unregulated government research project on Minnesota patients with no consent required. With that particular date in there that is now, this bill is trying to sunset, was put in there because of the controversial nature of the database. And thus we oppose repealing the sunset date and instead encourage the committee to repeal the entire law, as we have asked for numerous times before. Thank you for your consideration of our concerns.
Thank you for your testimony. This is a policy committee and not a finance committee. So Representative Zerwas or the department, do you want to respond to the policy concerns of Ms. Braze?
Thank you, Mr. Chair, members, and I just want to be really clear. Other than Ms. Braze's Citizens Council for Health Freedom, I've had no other groups or entities approach me with opposition to the bill. The Council of Health Plans and none of the health plans have come to talk to me about this being a financial burden or a hardship on them or their staff. The information that we gather and that the department analyzes that's aggregated and de-identified is unbelievably valuable when we're trying to identify macro trends in how patients are diagnosed, treated, and what long-term prognoses are. It's data that this committee and several subcommittees, certainly Senator Jensen's committee in the Senate that met throughout the interim, it's data that those committees have used intensively to make long-term health policy decisions for the state of Minnesota. It's unbelievably valuable information that has reaped untold benefits for the future of healthcare in the state of Minnesota, it would be foolish to abandon it at this point.
Ms. Braze.
Mr. Chair, I would just like to mention that both the Minnesota Constitution and the U.S. Constitution have the Fourth Amendment language in it about the government not taking data, right? And so this is a very large government database, and it is being taken without the consent of patients. Most patients have no idea that the health department has all this data and the analysis that they are doing on it. And so we have always considered it a violation not only of patient rights, but of constitutional rights. And then secondarily, Mr. Chair, Representative Zerwas and the Health Department have not yet answered the question, and perhaps Representative Zerwas has never even considered the question, and so wouldn't be the right person anyway. But has not answered the Health Department has not answered the question about what they have done regarding the Vermont lawsuit and the ERISA-protected companies in the state of Minnesota.
Maybe the department would like to come down and respond to those questions.
Well, Mr. Chair, I have no concerns with the department coming down and providing testimony as to the All Players Claims Database and how the program operates and the benefits that's shown. I want to be really clear that with all due respect to Ms. Braze, as a testifier in this committee, she's not in a position to grill the department and ask the department questions. If members have questions for the department, that might be appropriate, but otherwise, I don't think it would be.
All right, thank you, Representative Zerwas. Representative Albright.
Representative Zerwas, I'm looking at line 2.9 and 2.10, and this might be a question for Health Research as well. But I'm just wondering if that date also needs to move out to 2019, because if I look at page or point or line 1.21, it says to compile one or more public use files of summary data or tables that must, and then it leads me to V, not lead to the collection of additional data elements beyond what is authorized under this section as of June 30th. Are we in conflict with the amendment to move it to 2019?
Ms. Clark-Bist.
Mr. Chair and Representative Albright, no. That's Clause 5, and Clause 5 talks about public use files. The amendment is removing a restriction on the use of data under Clause 3.
Okay.
Representative Albright.
Thank you, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair. Just a brief comment, Representative Zerwas, I support this bill.
Clock's right twice a day.
That's what I mean.
You got to take a picture of that.
Representative Halverson.
Thank you. I can't let this discussion go without commenting. Data is so vital to the work we're trying to do as policymakers, particularly when we get to what's driving cost within our system. And I think that universally, that's something we're all really trying to understand, and we can't understand it without data. So let's do it. I think let's pass this bill. I think it's a great idea. The one example I keep thinking of right now is when I worked in the private sector, I was part of helping to carry out a study with regard to leading causes of preventable death in Minnesota when I worked for a large health plan in the state. And it turns out tobacco was the leading cause of preventable death in the state of Minnesota. And Minnesota became the first state in the nation to sue the tobacco companies. And we have reduced smoking rates by, I can't even think, more than 10%. So we've had historic changes happen because of the way that we've used data, and Minnesotans are healthier for it. So let's work together and keep our data coming at us.
Thank you, Representative Halverson. Is there anyone else who wishes to testify on House File 3398? Seeing none, are there any other questions from members? Seeing none, final word, Representative Zerwas.
Thank you, Mr. Chair, and thank you, members.
With that, Representative Gruenhagen renews his motion that House File 3398 be re-referred to the Committee on Civil Law and Data Practices Policy. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3398 is re-referred to the Committee on Civil Law and Data Practices Policy. All right, next up is House File 3323. I will move the House File 3323 be re-referred to the Committee on Health and Human Service Finance. Representative Zerwas, we have the bill in front of us. To your bill.
Thank you, Mr. Chair and members. House File 3323 was brought to me by the folks at Sherburne County and the Minnesota Inter-County Association. The bill addresses county challenges relating to hospitalization criteria for county clients ready to be released from the Anoka-Metro Regional Treatment Center and community behavioral health hospitals. The bill does four things. When a person no longer meets hospitalization criteria at the AMRTC or a CBHH, a county then pays 100% cost of the care until the person is released to the county. Under this legislation, when a person is ready to be released from either of those facilities but needs competency restoration at any competency restoration program, CRP, or community competency restoration program, CCRP, counties would not be responsible for the cost share. AMRTC, CBHH, CRP, and CCRP are all state-operated services. Counties should not be held financially responsible for the cost of care when placement, transfer, and admission into one of those settings is completely within the control of state-operated services. And so I think the challenge is within Sherburne County and other counties, we've had multiple instances where the county is notified at 4 p.m. on a Friday, and it says client A no longer meets the hospital criteria, and the full per diem amount is now going to be borne by the county, but the county is notified so late on that Friday afternoon that placement isn't really possible until Monday at the earliest. And it doesn't take long for a couple individuals with unplanned several day stays in these facilities really add up, and for smaller counties in greater Minnesota have a huge impact on their budgets. And so the bill would require a 10-day notice to counties and the commissioner prior to discharge of a client. It also requires DHS and the facility to partner with counties to find appropriate placement prior to discharge. If the client is not discharged due to any delay caused by the county or the facility, the county shouldn't bear that extra cost. It requires DHS to keep a comprehensive wait list so counties have knowledge as to where beds might be available, and it amends the Fair Hearing Acts so counties can appeal when they dispute responsibility for the 100% cost share due to a delay that is, the delay is because of when DHS notified the county, and that's one of the challenges is in current law, there's a dispute resolution appeal process, but this 100% cost share isn't one of the things that you can appeal. So the counties are kind of left holding the bag. With me today is Mary Jo Cobb, the Health and Human Service Director at Sherburne County, who will try to help walk through the current process that Sherburne County and many other counties are facing.
Welcome to the committee. If you could please state your name for the record and present your testimony.
Excuse me, my name is Mary Jo Cobb, and I am the director, as Mr. Representative Zerwas said, Director of Health and Human Services in Sherburne County. I'm here to testify in support of House File 3323 on behalf of Sherburne County, the Minnesota Intercounty Association, otherwise known as MICA, and the Minnesota Association of County Social Service Administrators, MACSA. This evening, I want to share the reasons why I'm in support of the language changes proposed in this bill. Between Anoka-Metro Regional Treatment Center and the community-based behavioral health hospitals in 2016, counties paid $23.3 million for days of care labeled as do not meet medical criteria. In 2017, that amount was $18.7 million. Counties pay whether or not they have the ability to move the client to another facility, whether notice was received timely, or if there is a bed available. Sherburne County's costs were only a small part of those numbers, but still significant to our budget. In 2017, Sherburne County had 4 individuals who remained at Anoka-Metro Regional Treatment Center when they no longer met medical criteria for hospitalization. In one case, we received a fax on a Saturday that medical necessity had ended. Since no one was working to facilitate a discharge, we paid for Saturday and Sunday, and that rate is $13.75 per day, $1,375 per day. In another case, the agency was notified on a Friday that medical necessity had ended. We offered to move the client that day, but were told by hospital staff that they would not have the discharge paperwork completed until the following week, and we were billed for the extra days. Sherburne County had 2 other clients in 2017 who stayed 12 and 37 days after they no longer met criteria for hospitalization, and appropriate placement options were not available to them. Those 2 clients cost the county nearly $100,000. Overall impact on Sherburne County for 2016 was $115,000, and for 2017, the cost was $107,000. But as I stated earlier, statewide, the cost was $23.3 million and $18.7 million for those years. As a representative of MACSA, I can assure you that all counties support this bill. An option to appeal these costs would be very helpful. Counties already use an existing appeals process when we disagree between ourselves on who is financially responsible. A similar appeals process could be used when the counties and the state disagree on who is responsible for payment. We believe that this bill will create more transparency in decision-making and discharge planning for clients. The language says, the commissioner and facility shall partner with the county to find appropriate placement for the client by the discharge date on the notice. We believe that creates a shared responsibility for the continuing care of persons with mental illness, and we are very willing to partner with the commissioner and facilities to make this happen. Thank you.
Thank you, Ms. Cobb, for your testimony this evening. Are there any questions for the testifier? Representative Sandstedt.
Thank you, Mr. Chair. Did I hear you correctly in saying in one of your scenarios it took a week to receive discharge papers?
Ms. Cobb.
The next week.
Okay.
Representative Sandstedt.
Thank you.
Are there any other questions for the testifier? Seeing none, is there anyone else who wishes to testify in House File 3323? Make your way down, please. Welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. I'm Wade Brost. I'm one of the executive directors for the Department of Human Services Direct Care and Treatment. Again, thank you for having me today. We've had the opportunity to present some of our concerns with this bill to the author as well as the stakeholders, and we'll continue to partner with them if necessary or wanted. But we do want to just make a couple points that we do believe that the cost of care language that's in place today has served a valuable asset in helping to, thank you, that the cost of care language that's in place today has served a valuable tool in helping counties be more engaged in effective discharge planning at our facilities. Since the inception of the 100% county cost of care in 2015 at AMRTC and then 2016 in our CBHHs, we've seen better county involvement and more effective discharge planning and collaboration. We've also seen a steady decrease in our do not meet hospital criteria days in both programs, and we've seen that trend continue to decrease. So we do feel that it's valuable, but we stand ready to work with this group on the language that's presented today, because it does present us with some potential concerns, and I can point out a few of those right now. Around the 10-day criteria, We currently operate under federal regulation that mandates us notice the patient the day that the determination is made. And oftentimes it's impossible to identify when a person's going to be psychiatrically stable and their symptoms are no longer presenting as hospital level 10 days in advance. Psychiatric symptoms are very fluid in nature, and sometimes that determination is made hours before the patient is notified. In regard to the list of discharge placements, it's written very broadly, and we have had some initial conversations, but as written, it would require DHS to create a list of all discharge placements throughout the state, which is essentially unmanageable and impossible to operate or to implement. We do have a bed management program for internal DCT, direct care and treatment placement options that we do manage and can potentially work with the author and the stakeholders to develop some language that could look at sharing that. The appeals process. Right now, there is not an appeals process, and if one was established, we do anticipate that there would be employee resources needed to support that. There's one other point that I neglected to offer right away, and I apologize, but in the first part of the bill, around the 10-day notice, if under current regulation, if we don't bill the county, we will be obligated to bill the patient. So that's something that I want to note to this committee as well. I don't think anyone's intent is to bill the patient, but again, DHS stands ready to work with stakeholders if wanted.
All right, thank you, Mr. Gross. Are there any questions for the testifier? Representative Liebling.
Thank you, Mr. Chair. Not so much a question, but, well, I'm really glad to hear that you're working on this. This has been a problem for a while, and it really needs solution, but I know it's really a difficult problem. It's got a lot of aspects to it, so I think it's good if the stakeholders are working together. The one thing that I really kind of jumped out at me is that the commissioner and facility shall partner with the county to find appropriate placement for the client. You know, when we have language, I worry that when we say you're going to partner, that it means nobody's responsible. And I know that when we've made changes with this system, you know, we hear in this committee a lot about the backups in emergency rooms and what we did with that 24-hour jail rule that was passed some years ago. So when we tweak the system, we run the risk of impacting the whole system when people either stay too long. If they end up staying too long at Anoka, then we, you know, I mean, it just has these ramifications. And so, you know, I hope that we can get to a place before this bill actually gets passed where everybody's pretty comfortable with trying a new thing, because I'd hate for us to make another mistake. So that's all.
Thank you, Representative Liebling. Are there any questions for the testifier? Seeing none, Mr. Gross, the committee thanks you. Welcome to the committee. Please state your name and present your testimony.
Thank you, Mr. Chairman. Member Sue Abderholden, Executive Director of NAMI, Minnesota. I will say that I think that when this law went into place, it really was one of those unintended consequences and really has turned out poorly. Not only are the counties, you know, have this huge bill for 100%, but the money goes into the general fund and doesn't really help us build our mental health system at all. But I am worried, it was just, you know, just mentioned that it's the patient who is there involuntarily who is now going to get part of the bill. And, you know, if they've been there for several months, if they came from the jail, they probably don't have much money, so I'm not kind of sure how much the department actually, you know, tries to get the money from them. But I think it's something that should be part of this discussion, and Representative Zerwas and I have emailed back and forth on it just to be sure. And I've talked to the department a little bit, but I just don't want to have this kind of fall to the patient who probably doesn't have much money anyway. And just a reminder that, you know, Medicaid doesn't pay at Anoka because it's more than 16 beds. There's a little bit of Medicare dollars, a little bit of private insurance, and then what isn't paid, that a percentage, depending on where it is in the law, then the county pays. And what's left is actually for the patient to pay. And if it gets to a lot of money, that could be a problem. So just wanted to raise that.
Thank you, Ms. Abderholden. Are there any questions for the testifier? Seeing none, the committee thanks you for your testimony this evening. Is there anyone else who wishes to testify on House File 3323? Seeing none, are there any final questions from members? Seeing none, final word, Representative Zerwas.
Mr. Chair and members, thank you for taking the time with the bill. I think the challenge is for the counties. I understand the concern around the viability or the workability of a 10-day notice period, but I think we can all agree that sending a fax on a Saturday afternoon and then having the county on the hook for 100% of that tab in the intervening weekend doesn't seem like a great solution either. And when I look at the amount of money that one of my counties, Sherburne County, has to spend on community mental health within Sherburne County, and I look at the cost that just this one change in law has shifted onto Sherburne County of over $100,000 a year, that's a significant burden for our county to pick up, and $23 million statewide in county share. The state DHS is managing both the patients, determining when they're ready for discharge, and are in charge of the placement. So when DHS can't find a placement, the bill goes to the county. I think that's odd, and I think we ought to look into that. With that, I'd ask you to renew your motion, Mr. Chair.
With that, I will renew my motion that House File 3323 be re-referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3323 is re-referred to the Committee on Health and Human Service Finance. Before we move into the next Zerwas bill, I do want to quickly bring up House File 3202 again, and I'll just do it from the table here quick, members. The agreement was, or the request was that we keep the bill here. We are going to move it forward. The Rules Committee was unwilling to grant any kind of waiver because it opens the door to other things, but the agreement that we have, that I was able to make with Representative Liebling and Representative Halverson, is that as the bill is on the floor, it stays on the floor, will not be voted on the floor until we've had the chance to have another hearing after the preliminary report comes out from the Department of Health on this one. And so I'd ask for your support, and I'd ask for no roll call on this, if we could do that. And with that, I will renew my motion that House File 3202 be re-referred to the General Register. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3202 is re-referred to the General Register. Thank you, members. Next up, House File 3366, Representative Zerwas. I will move that House File 3366 be re-referred to the Committee on Civil Law and Data Practices Policy. Representative Zerwas, we have the bill in front of us whenever you're ready.
Thank you, Mr. Chair and members, and see just a couple bills of listening to this soothing voice, and all parties are ready to agree. I just have that magical effect. House File 3366 was brought to me by the Department of Health. It deals with giving access to birth data and birth certificates to tribal governments. In a weird twist of state law, currently tribal governments don't have access to the non-public data involved in birth certificates and birth records. And the Department of Health asked me to carry a bill to rectify that for efficient record management of the tribes and other work that they do in operating tribal government. I've had no individuals come to me with objections, and I do have a testifier from the department to provide some background.
Welcome to the committee, Ms. Crawford. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair, members of the committee. I am Molly Crawford. I'm the State Registrar for the Minnesota Department of Health, Office of Vital Records, and I'm here to testify on behalf of House File 3366. This bill addresses a provision in current law that prohibits tribal health professionals from accessing critical information about births in their community and using that information to provide effective services to at-risk mothers and babies and support to families. It also addresses a long-standing inequity by giving tribal organizations the same level of access to information that county public health and other government programs already have. So at the time of birth, a variety of demographic and health data is collected to register the birth. This information is important to many people, including the individuals. It also helps local public health programs identify and follow up with the at-risk newborns and mothers, and it helps child support agencies establish legal parents and collect money for families. Minnesota law classifies the birth information in different ways. Medical information about the birth and about the mother's or infant's health is classified as private. Demographic information, such as names, dates of birth, or addresses, is classified as public if the mother is married, but confidential if the mother is unmarried. The law also governs who can have access to the private or confidential information and for what purposes. Currently, the Department of Health is allowed to provide private and confidential data, including for unmarried births, to county public health agencies, community health boards, and collaborative family services and community-based programs that perform specific activities, such as home visiting for high-risk mothers and infants. The law does not allow tribal health departments or tribal child support programs to have access to health or demographic information about unmarried mothers in their jurisdiction, nor does it allow tribal government to get legal birth certificates as other local, state, and federal government programs do. As you know, American Indian infants have the highest infant mortality rate of any community in Minnesota, more than twice as high as for Asian or white infants. Yet, under current law, public health tribal nurses are not allowed access to this important data to deliver those critical services and support those families. This bill would allow tribal health departments and tribal government programs to have access to the same type of information that county health departments and child support programs already receive. It's an important step towards addressing disparities in health throughout the state. Thank you.
Thank you, Ms. Crawford. Are there any questions for Ms. Crawford? Seeing none, the committee thanks you for your testimony.
Thank you.
Is there anyone else who wishes to testify on House File 3366? Mr. Flanders, we had you on the list. Nope, okay. Anyone else? Are there any questions from members? Final word, Representative Zerwas.
Thank you, Mr. Chair. Thank you, members.
With that, I'll renew my motion that House File 3366 be referred to the Committee on Civil Law and Data Practices Policy. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3366 is referred to the Committee on Civil Law and Data Practices Policy. Next up, House File 3367, Representative Zerwas. I'll move that House File 3367 be referred to the Committee on Civil Law and Data Practices Policy. Representative Zerwas, whenever you're ready, to your bill.
Thank you, Mr. Chair. Thank you, members. House Bill 3367 is a housekeeping bill that allows advanced practice registered nurses to complete the necessary paperwork for the care they are already providing on a daily basis and cleans up outdated statutes that only reference physicians. This bill is an extension of last year's signature bill that also made changes to various provisions in Minnesota law, allowing APRNs to complete paperwork associated with care. Following the 2017 legislative session, the APRN Coalition and the Minnesota Nurse Practitioners held several meetings with the Department of Human Services and the Minnesota Department of Health to review outdated statutes and rules related to APRNs. This bill is a product of those meetings. This bill is not a scope of practice bill. It does not in any way change the what APRNs are allowed to do. It eliminates delays and duplication of workforce by the need to find physicians to sign a form for a patient the doctor has not seen. It promotes transparency and accountability by recognizing documents from advanced practice nurses. The bill so far has been non-controversial. The following stakeholders have reviewed the bill and have had no objections: the Minnesota Medical Association, the Minnesota Board of Medicine, the Minnesota Board of Nursing, the Minnesota Department of Human Services, and the Minnesota Department of Health.
All right, is there anyone who wishes to testify on House File 3367? Welcome to the committee. If you could please state your name for this bill and present your testimony.
Thank you, Mr. Chair. Twyla Bray, Citizens Council for Health Freedom. Again, I have spoken with Representative Zerwas about this bill, and I'm speaking as both a registered nurse, a public health nurse, and as the organization's president. And I guess what I'd like to start off with is just to say that we're concerned about the scope of practice, but particularly it being independent from the practice of medicine. And I guess what I'd like to do is just say my own situation. And that is that I had a fractured toe. I went to the orthopedist clinic to get it looked at because I wasn't sure it was fractured. I was pretty sure it was fractured. But anyway, the only option for me was a nurse practitioner. And the nurse practitioner took an x-ray, told me that I had fractured my great toe, and told me there was nothing I needed to do and it would heal on its own. I could walk barefoot, etc. And so I went home, and that's exactly what I did. And then when I taped the big toe and the second toe together, just for stability, and after about 2 weeks or so, my second toe started to hurt. And so I went back to the orthopedist and found, oh yes, I forgot to tell you, the nurse practitioner told me, when I said, who else is going to read the x-ray, the nurse practitioner said, no one. In this state, no one has to read the x-ray, not even a radiologist. And so I went back to the nurse practitioner, I went back to the clinic, to the orthopedist, who told me I had fractured both toes. And told me that I should be in Dansko shoes, and gave me a special, I should never be walking barefoot, and gave me a special insert for the shoe. So what we have here is an error made in both diagnosis and in treatment. And so when I look at the what's happening here with the expansion of nurse practitioners, and I realize this has been called the housekeeping bill, but anytime you change the law, you expand the power. And if it is indeed patients that have not been seen by a physician, might there not be a reason, particularly in advanced directive planning, that there should have been maybe a physician? So I just want to bring your attention to the fact, in case you do not know, that there that in this transfer of scope of practice, the physicians have 20,000 hours of training, clinical training, and nurse practitioners can have as little as 620 and do it online. And there are nurse practitioners in an article coming up that will talk about how they feel, they're very concerned about people getting into the nurse practitioner programs, the online programs, that don't even have to have any RN experience. And so I bring this all to your attention to just say that I think as a legislature, there's just the thinking here that it's the same, or that they can be the same. There's even bills for parity in this legislative session. But just for another piece for you to have is that the Mayo Clinic studied the difference between referrals to the Mayo Clinic by physicians, nurse practitioners, and physicians' assistants. Physicians scored higher in the quality of the referrals, including items such as understanding pathophysiology and doing pre-referral evaluations. And the study also states the following: although some may argue that using nurse practitioners and PAs reduces healthcare costs, our study findings suggest that inappropriate referrals to tertiary referral centers by nurse practitioners and PAs could offset any potential savings. The American Association of Nurse Practitioners and their comment about what's happening here and their desire for pay parity should make you consider the fact that it's not going to reduce costs, this transition to really put nurse practitioners at nurses with just additional training in the role of physicians. Oregon is the first state to do it. And we know that there are bills here to do the very same here. So will be less training for the same cost. So for the sake of patient safety and that other patients do not end up misdiagnosed, et cetera, I would encourage you to think before expanding what nurse practitioners can do in place of physicians. They have nothing near the training and the clinical training or the time as physicians do.
All right, thank you, Ms. Braze, for your testimony. Are there any questions for the testifier? Representative Liebling.
Thank you, Ms. Braze. There was some conversation over here about the fact that you shared some of your private data with the world.
Yes.
Yeah.
So we all know now that you had 2 broken toes.
Yes.
But so it must be getting late. So I think that some of the things you're raising, I'm familiar with the study that you have mentioned, and, I was not a big proponent of the entire bill to give APRNs complete independence and so on, but we did, and this bill isn't about that. I think the bill, as I read it, it just is, I would call it, maybe it's not entirely housekeeping, but I don't see it as an expansion of the scope. I think there's still, one of the big pushes for giving APRNs independence was that this was going to help the shortages in greater Minnesota. And we were going to, we often hear this around here, that this is about access, and this is because APRNs are going to go and be able to practice independently, and they're going to go to places where there are shortages. And I have yet to see whether that's actually occurring. I hope it's occurring. I kind of doubt that that's really occurring. But in terms of, I think that you're bringing up some issues that, while I think there might be room for discussion of some things, that horse left the barn, and this bill is not sending any more horses out of the barn. So I support the bill, and but thank you for raising the issue about that study. I hope that that's just one study. You can't make great decisions on one study, but I hope there will continue to be some analysis. In Minnesota, we've done very well by having our health providers practice in teams, and hopefully the future is people working together. And one of the concerns with the independent practice legislation was the idea that people were just going to go out on their own and practice on their own, kind of contrary to what we tend to think is the best way to practice, which is, as I said, in teams. But, I support the legislation. Thank you for being here tonight.
Thank you, Representative Liebling. Are there any other questions for the testifier?
Mr. Chair.
Ms. Braze.
Just to add one more thing, in an article that is going to come out on kevin.md, the article is going to be titled, Nurse Practitioners Respond to Concerns About Independent Practice, and it has a bunch of quotes from nurse practitioners, and one of them is Sherry from the Chicago area, and she says, and she is a nurse practitioner, and she said, "But I will never believe my training is equal to a physician. Keep up your fight for the safety of all mankind, for someday we will occupy those critical care beds too." And she is concerned about the drive to make the two practices commensurate. Thank you.
Thank you, Ms. Braze. Is there anyone else who wishes to testify on House File 3367? Seeing none, questions from members? Final word, Representative Zerwas.
Well, thank you, Mr. Chair. Thank you, members. Just so there's not any confusion, if you look section by section through the bill, it is allowing nurse practitioners that are seeing their patients sign for what they talked to a patient about or a test that they saw, rather than having a physician sign for a patient. The physician didn't see a patient and was told by the nurse practitioner what the nurse practitioner saw, and then the physician signed it. That is the only change in this bill, in the 10 sections of this bill, and that's all the bill does.
With that, I'll renew my motion that House File 3367 be re-referred to the Committee on Civil Law and Data Practices Policy. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3367 is re-referred to the Committee on Civil Law and Data Practices Policy. Next tonight, House File 3201, Representative Zerwas. I'll move that House File 3201 be re-referred to the Committee on Health and Human Service Finance. Representative Zerwas, whenever you're ready.
Thank you, Mr. Chair. Thank you, members. House File 3201 is a very similar approach to the AMRTC CBHH bill that we had earlier. This was also brought to me by Sherburne County and the Minnesota Inter-County Association. The bill addresses county challenges relating to hospitalization criteria for county clients ready to be released from the Anoka-Metro Regional Treatment Center. Current law requires counties to pay 100% of the cost when the person no longer meets hospitalization criteria. This bill would modify a county's payment of the cost care so the county share shall align with existing rates for the needed level of treatment of care, regardless of the facility in which the client is located in. And so this is another attempt to try to lessen the burden on our county property tax dollars, trying to, when a county has someone in AMRTC, they're notified that the person no longer meets the medical requirement or the medical criteria for admission, but they're not yet been placed in the community to try to make it so the county doesn't have to cover that full cost. With me today is Mary Jo Cobb, once again, the Health and Human Service Director at Sherburne County, and we'll be brief with this bill, knowing that we just covered the previous one. Thank you, Mr. Chair and members.
All right, thank you, Representative Zerwas. Welcome back to the committee. Ms. Cobb, if you could reintroduce your name for the record for this bill and give us your testimony.
My name is Mary Jo Cobb. Mr. Chair, members of the committee, as Representative Zerwas indicated, I'm Health and Human Services Director at Sherburne County. I'm here to testify in support of House File 3201 on behalf of Sherburne County, MICA, and MAXA. My testimony earlier this evening speaks to this bill as well and addresses our county concerns with the current legislation. This bill addresses a similar component to House File 3323 in that when a client does not meet medical necessity and is ready to be released to a competency restoration program, that the county should not be responsible for the cost at AMRTC. These are state-operated services, and counties do not have control over where people go or the wait lists. Any movement on these bills will prove helpful to counties. This allows for more shared responsibility between the state and counties in meeting the needs of our citizens with mental health issues. Thank you.
Thank you, Ms. Cobb, for your testimony. Are there any questions for the testifier? Seeing none, the committee thanks you for your testimony. Is there anyone else who wishes to testify on House File 3201? Seeing none, are there any questions from members? Final word, Representative Zerwas.
Thank you, Mr. Chair and members, and thank you for the committee's patience in sitting through my 5 bills tonight. Appreciate it.
With that, I will renew my motion that House File 3201 be re-referred to the Committee on Health and Human Service Finance. All those in favor signify by saying aye. Aye. Opposed, same sign. The motion prevails, and House File 3201 is re-referred to the Committee on Health and Human Service Finance. Next up, House File 3823.
Okay, Representative Schomacker moves House File 3823 to be referred to the Committee on HHS Finance. Representative Schomacker, I understand that you have a DE1 amendment. It's an author's amendment. I move the DE1 amendment. Representative Schomacker, to your amendment when you're ready.
Thank you, Mr. Chair and members. This DE1 amendment is really just aligning with the new version of the language of the bill. So it's just getting into the order that I wish to present tonight.
Any discussion on the DE1 amendment, members? Seeing none, all those in favor say aye.
Aye.
Those opposed, same sign. The motion prevails and the DE1 amendment is adopted.
Thank you, members.
Chair Schomacker, please give a brief explanation of your bill as amended.
Thank you, members. House File 3823 establishes a health policy commission. What we're trying to do here is provide input and recommendations on how we as a state can better achieve improved care and health outcomes at lower costs through our commercial market and public programs. And through that, we are establishing an independent health policy commission. This independent commission will work to understand why Minnesota ranks so high in healthcare costs and spending, identify what the drivers are of escalating healthcare costs and spending in Minnesota, and offer recommendations about policy, legislative, and market reforms that can be undertaken to bend the cost curve and improve care and quality for all Minnesotans. It will provide regular reports and input to the legislature and will be supported by permanent professional staff with the expertise to skill set necessary to necessarily help them and the commission fulfill its mission. The commission will be populated with independent experts with demonstrated expertise in health finance, health economics, actuarial science, consumer advocacy, and health plan and health system management. It will also include representation from employers and purchasers of health insurance, physicians, those who provide services through MA, and those who depend on Minnesota's public health care programs. To ensure the Commission's independence, a select group consisting of the state economist, the state demographer, the legislative auditor, and the president of the Federal Reserve Bank of Minneapolis will recommend individuals for appointment to the commission, and the Legislative Coordinating Commission will make appointments to the commission from that recommended group. With that, members, I have with me today Bentley Graves, who can provide a little testimony and help answer any questions you may have.
Mr. Graves, please introduce yourself and try to keep your testimony within 2 minutes if possible.
Thank you, Mr. Chair and members. My name is Bentley Graves. I'm with the Minnesota Chamber of Commerce. I want to thank Chair Schomacker for bringing this legislation forward. There is data that suggests Minnesota has some of the highest commercial health care costs in the country, and there's also a lot of data that suggests that we paid at a very high rate as compared to other states for our public program enrollees. And the idea behind this commission is, as the chair said, is to bring independent experts around some of these questions about what's driving costs in our commercial market and our public programs, and make some recommendations to the legislature about how to bend the cost curve at both ends of the spectrum of healthcare. Again, this is a significant concern for our members, where healthcare costs are a daily concern for them, and being able to provide coverage for their employees, keep their employees productive and healthy at work, and also continue offering that benefit as a way to attract talent and retain talent. But we know is a growing concern in our public programs as well. So I want to thank Chair Schomacker for bringing this forward. Certainly happy to answer any questions there may be, but I'll leave it at that given the time constraints. Thank you.
Chair Schomacker, do you have any other testifiers?
I believe there are others who are wishing to testify in the bill, but they are not mine.
Okay. So you're disassociating yourself with them, right? Is there anyone else in the audience that would like to testify for or with concerns about the bill? Please come forward. I don't recognize you because I don't have my glasses on. Please introduce yourself. And give a brief testimony, which will be timed for 2 minutes. Representative
Mr. Chairman, members of the committee, for the
Just
record.
kidding.
My name is Mary Krinke, and I'm with the Minnesota Hospital Association. And I know you're going to find this hard to believe, but I've been lobbying for 27 years. And yes, I did start when I was 10 years old. But during that time, there have been numerous task forces and commissions and healthcare groups that have gotten together. Some have been appointed by the governor, some have been appointed by the legislature. And I know it seems unusual to be opposed to a commission or task force, but there are a couple things that I would like to point out. On 2.8 of the bill, it says that the legislators are just going to be ex officios. we would really encourage you to have legislators serve on this commission. Commissions are generally more successful if they actually have legislators involved, because then otherwise this is just another think tank. I'd like to know why this is any different than the American Experiment or some other outside group. You really, if you want to have success and move something at the Capitol, you really need to have legislators involved in the process. I'd also like to point out that several of the things that are in the charge for this commission is work that is already being done by DHS, our Health Economics Department, and as well, quite frankly, our nonpartisan staff here at the Capitol. Also, you can get information on comparative analysis of how our Medicaid state spending is compared to other states. That's available from the National Governors Association, the American Exchange Council, and National Conference of State Legislators. So there's a lot of this information that is really easy to get. While we're not supportive of the bill, I do have a suggestion that I think would make us feel more comfortable with it. If you look at the last page of the bill, it has a sunset date of June 15th, 2034. That's a really long time out for a sunset date, and we would like to suggest that it perhaps would be lining up with the next governor, and maybe have a sunset date of December 31st, 2022. Maybe look at this and say, hey, if they've done something successful and good in 4 years, great. But otherwise, you're putting in a lot of money to create a new, somewhat state agency, independent, and we would really recommend sort of narrowing this a bit. Thank you, Mr. Chairman.
Thank you, Ms. Krinke. Chair Schomacker, any comments?
Yes, Mr. Chair, members of the committee, I just thank MHA for their candor this evening and bringing up some of the concerns that they have. Of course, this is a new idea. It's something that we're trying to bring forward that has a little bit of a different perspective, and so we're going to be open to all ideas as we move forward to get something that's workable that we can move forward with.
Anyone else who wants to testify for or with concerns about the bill? Please come forward and introduce yourself, and try to keep your testimony within 2 minutes if possible.
Mr. Chair and members of the committee, my name is Matt Flanders, and I'm the legislative specialist with Citizens Council for Health Freedom. We appreciate this opportunity to testify and share 5 concerns regarding the Minnesota Health Policy Commission established by House File 3823 as amended by the DE1 amendment. The Minnesota Health Policy Commission is heavily weighted towards the industry, not the consumer. The makeup of the 11 voting members is mostly industry representatives, with only 2 consumer or patient representatives. This will be a commission of the health industry established by the government. Line 3.8 also instructs the commission to include drafts of legislation. Thus, we believe the industry will drive the policy recommendations coming out of the commission. The Minnesota Health Policy Commission will also be given access to data collected by the government agencies. This patient health information will be used without the patient's consent. The commission will also be able to disclose de-identified data. However, de-identified data can and has been re-identified according to the Department of Health and Human Services de-identification standard. Regarding lines 4.10 through 4.12, how often could these meetings be closed to the public? We're concerned that de-identification of data could come up often, leaving the public in the dark. This bill also establishes a new Health Policy Commission Advisory Council comprised of 4 government representatives who will be empowered to create the final list of applicants from which the legislative coordinating commissions shall choose members. House File 3823 creates this commission that will begin in 2019 and not expire until 2034. That is 15 years of taxpayer money to compensate commission members, the director, staff, and consultants. This cost can be high. For example, in 2011, Minnesota contracted with Jonathan Gruber, who later became a controversial figure, and Gorman Actuarial to analyze the ACA's impact on the state exchange for a total cost of $560,000. In conclusion, House File 3823 establishes a new government council and creates an industry-led commission that we believe will drive the industry's policy agenda. It will also allow government and the industry to work together against the interest of patients and enrollees. It also enables sharing of private health information, creates another layer to the bureaucracy that doesn't end for at least 15 years, and expends an unknown amount of taxpayer money, which may increase over the years. For these reasons, we oppose this bill, and thank you for your consideration.
Thank you for your testimony, Mr. Flanders. Is there anyone else in the audience that would want to testify for or with concerns about the bill? Please come forward and introduce yourself and try to keep your testimony within 2 minutes if at all possible.
Mr. Chairman, members, Sue Abderhold, NAMI, Minnesota. I'll be very fast, and I'm sorry, Representative Schomacker, I didn't get a chance. I had a lot of bills this week. The only suggestion we have is that to include someone with a background in mental health, because when you look at some of the costs associated with healthcare, it's often someone with heart disease who has untreated depression. There's a lot of co-occurring illnesses there. And we find that the regular healthcare system has no idea how the mental health care system works. So I think it would just be helpful to have someone from the mental health provider community or advocacy community be a part of it. Maybe not advocacy, just have the providers be on there instead. But I don't want to do it. But it'd be good to have someone on there. Thank you.
Thank you for your testimony, and we'll note that you don't want to be on the committee. With that, members, is there any other questions from members that are sober and meaningful? Okay, it's getting late. Okay. I didn't sleep good.
Mr. Chair, was that on the script?
Who? Oh.
Mr. Chair, was that on the
Representative
script?
Krisha.
Sorry.
Or what? Oh, follow the script, yeah. That was on the script. No, seriously, members. Okay, do we have any questions? Do we have any answers? No, just kidding. Okay, with that, Representative Schomacker, do you want to make any final comments?
Just thank you for your support.
Okay, thank you, Representative Schomacker. Representative Schomacker renews his motion that House File 3823 be referred to the committee.
We gotta get through the rest of
It does say her, but I said he, okay? To the Committee on HHS Finance. Those in favor of the motion say aye.
Aye.
Those opposed, same sign. Aye.
No.
The motion prevails, and House File 3823 is referred to the Committee on HHS Finance. Okay, with that, we'll have a gavel.
All right, members, the final bill up for tonight is House File 2023. Representative Omar. As she makes her way forward, I will move that House File 2023 be re-referred to the Committee on Government Operations and Elections Policy. Representative Omar, you have a DE1 amendment, is that correct?
Yes, Chair.
All right, I will move the DE1 amendment. Representative Omar, to your amendment.
The amendment simply just gets the bill into the shape we would like.
All right, are there any questions on the DE1 amendment? Representative Albright.
Thank you, Mr. Chair. And for the author of the DE, it certainly does get it in the manner in which you prefer it, but it is materially different from the bill itself, including fees. Representative Omar, I'm wondering how the fees were arrived at on page 9.
Representative Omar.
Chair, Representative Albright, I actually don't have the amendment. I'm not looking at the amendment. It is what was adopted in the Senate, and we would love to have it be the same bill that moves forward here.
Mr. Chair.
Right, Representative Albright.
Thank you, Mr. Chair. Representative Omar, with all due respect, the Senate proceedings do not have bearing on what we decide or debate in the House, and so my question still stands.
Chair, Representative Albright, noted. now that I am looking at the amendment, can you please re-reference where your question was?
And Representative Albright, I remind you that we're in the policy committee and this still has to stop in finance. Representative Albright.
I understand, thank you. With regard to the determination of the fees, with regard to the number of stakeholders to the bill, there has been years of comment made about the prohibitive nature of fees. And with regard to not the determination of the fees from a financial perspective, but from an availability of the interpreters to enter into their career path, I'm wondering what the dialogue was that set the fees.
Oh.
Representative Omar.
Wonderful, Chair. Representative Albright, as you've noted, you've probably all have seen reiterations of this bill long before I got here, and it's been deliberated, and a lot of stakeholders have stated their input in regards to setting the fee. The fee will increase within the next 3 years, and the amount of dollars is something that I think most of the people agreed on that stakeholder group. And we believe that as we move forward, these fees are going to be workable.
Representative Albright.
Thank you, Mr. Chair. Representative Omar, there are a number of additional or changes in a couple of the definitions at the front. I call your attention to both in the amendment subdivision 3 and subdivision, 8 is also there, but for the benefit of the committee members, I'm wondering if you could help us delineate the difference between a certified interpreter and a registered interpreter.
Representative Omar.
Chair, Representative Albright, that piece was in the bill. Do you need me to explain it now or explain it as I present the bill later?
Mr. Chair.
Representative Albright.
Mr. Chair, Representative Omar, we are under the DE, and so I think it would be helpful for the members to take a look at this in the context of adopting the DE before we move to the bill itself.
Wonderful, Chair, Representative Albright. So we've, in the bill and in the amendment, we are setting 2 categories. The first category is having someone be a registered interpreter that simply asks for someone to either take a written or an oral examination, or if they're not able to do that, take a training of 40 hours. And then the second and final category that we have is to have that person be certified, and the certification is a national certification for healthcare interpreters.
And Representative Omar, it looks like there may be a couple of questions on the DE. Would you like to present on the DE, and then that may help clear up some of the questions we have moving in? If you'd like to present, please go ahead.
Chair, if that's fine with Representative Albright, I could go with that. What this aims to do is to help reduce the disparities in healthcare outcomes for patients with limited English proficiency. And as I've noted earlier, this is a bill that we've been working on for many years. I've actually shown up here opposed to previous versions of this bill, and so this is a testament that this bill has gone through a lot of work, and if implemented, this bill will create a statewide standard for training and testing with the 2 categories that increases professional recognition. The first one is the registered category, which has a written and oral examination that will be designed and approved by the Minnesota Department of Health. Or a training that is also designed by them, and the requirement is to go through that training for 40 hours. The second category is to have a national certification. And then we have 3 hours of continuing education each year that will be implemented. The bill also creates an advisory council and a complaint process. With the fees that we will be collecting, it will allow for things like financial aid and other resources to be available to them. The advisory council will also be tasked with looking into seeing if any of the fees are imposing some hardships on interpreters, and passing their recommendations. And so we will revisit that if that is the case. It also allows for that fee to gradually be increased within 3 years if the bill is implemented. The fee from July 1st, 2019 to through June 30th, 2020 is going to be $50. From July 1st, 2020 through June 30th, 2021, it'll be $70. And then it caps at $90 starting July 1st at 2021. And with that, so the DE simply just updates and makes sure that we have we have included all of the inputs that we have received since we've introduced the bill last year.
Thank you, Representative Omar. Do you have any testifiers on your presentation?
I do.
All right. Welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Mr. Chair and members, for the opportunity to speak with you today. My name is Anjali Mishra Cameron, for the record, and I am the Research Director for the State Council on Asian Pacific Minnesotans. As a state agency, we're charged with advising you on behalf of over 300,000 Minnesotans descended from more than 40 Asian and Pacific Islander nations. I'm here today to share with you why our council believes that House File 2023, as amended, is an important step to ensuring that all Minnesotans receive the same quality of care. Our council represents a diverse community of both immigrants and refugees. Included in this population is over 30% English limited proficiency speakers. In some of our emerging refugee communities, those are our fastest growing and newest populations, like the Karen and Bhutanese. This number of limited English proficiency speakers is even higher. We've heard a strong call from our community members that they are not well served by the current roster system. This bill would require a minimum standard for medical interpreters in English proficiency and interpreter ethics to ensure that all Minnesotans have access to the safe and equitable health care that they deserve. Populations that rely on interpreters within the Asian Pacific community are some of our most vulnerable constituents. Without an interpreter, these patients remain silent bystanders in understanding provider instructions, in taking medications, and in making even the most fundamental healthcare decisions. Limited English proficient patients remain at the mercy of their interpreters to add clarity to what can be an already stressful hospital visit. For healthcare interpreters, this bill also provides a much-needed and transparent training and support mechanism. The creation of an advisory council is one of the most important features of this bill to assure best practices and an accessibility and affordable training option through the interpreters. It also requires that scholarships and additional funds be made available and advertised on the registry website. The process is critical to addressing the needs of our communities who speak rare languages and in greater Minnesota, which is something that the Advisory Council will specifically look at. Without any current distinction between trained and untrained interpreters, many members of our communities have shared their frustrations with us and choose to rely on family members rather than interpreters. This is not a model for quality health care. In a 2012 study of a Boston emergency department, it was found that family members or other ad hoc interpreters used resulted in a statistically significant increase in medical errors. Our council was created to uplift the voices of Asian Pacific communities. This bill strikes an appropriate balance between the needs of interpreters and the safety of patients. On behalf of our council, I ask you give careful consideration of this bill, and thank you.
Thank you, Ms. Camry, for your testimony this evening. Representative Omar, did you have anyone else testifying on your presentation?
Yes, I think we have a list of people.
All right, welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Mr. Chairman, and good evening, members. I'm so honored to be here tonight. My name is Maisia Lau, for the record, and I've been a Hmong interpreter for the community for about 6 years, and it makes me so proud to see how far we've come with this profession. Tonight, I hope that you can hear my experience and help establish a stronger existing interpreting roster system, or the HFS 2023 bill. I've had all the necessary training and have the highest certification in my language, which is the CCHI. Being an interpreter for the hospital, all these requirements are there to reassure our patients that they have the best team for their health care. It makes me proud to know that I can give back to my community and know that they will trust me. Another thing I'm proud of is that when I walk into a patient's room, their face lights up knowing that I can convey their messages and accurately. If it's a repeated patient, they welcome me, they look for me, and because they know I can understand medical terminology, I can help them get the answers they're looking for. At the end of each consult, I only have satisfied patients who leave with more knowledge and understanding than when they first walked in. That's the kind of service I hope for all limited proficiency patients. Why is this bill important to me? Well, I have parents who are not fluent in English. And like a lot of parents I know, hope that interpreters they receive will be able to explain to them their conditions. For instance, my dad suffers from hepatitis B. He goes to the clinic frequently, and one day he had an interpreter and as a routine checkup. During the session, instead of saying the word liver, the interpreter said heart. And just like that, my dad was confused and he was scared that he had a new condition. My dad knew his condition well, so he realized that maybe the interpreter may have misinterpreted. He later asked the interpreter to clarify. So to my dad, that was just a mistake. But to me, this shouldn't have happened. Not to my parents, not in clinics, and definitely not in healthcare. In my father's case, one misinterpretation changed the mood, the setting, and the concerns of his health. Can you imagine if it was an emergency case where medication was needed and it was needed to be given and an interpreter misinterpreted the wrong condition or whatnot? You know, my dad would have had to refuse or patients would deny medications and that would delay the patient's care. Situations like these do happen and they can be prevented by passing this bill. Passing this bill will only assure that family members will receive quality interpreters, understand their conditions and care, because to me, members of the committee, that is good health care. Thank you.
All right, thank you for your testimony, Ms. Levon. Welcome to the committee. If you could please state your name for the record and present your testimony.
Thank you, Mr. Chair. Mr. Chair, members of the committee, my name is Rosa Toc, and I am the Health, Policy, and Legislative Liaison for the Minnesota Council on Latino Affairs. Our council advocates on behalf of 300,000 Latino Minnesotans who contribute to the state's economy from working in the fields to businesses, research, philanthropy, hospitals, and clinics, you name it. So thank you so much for the opportunity to testify this evening. The council supports this bill. This is a bipartisan effort with 3 ultimate goals. The first one is to increase the cost efficiencies in the healthcare system which is very important as we are debating how to diminish healthcare costs in the state and in the nation. The second one is to improve patient outcomes. And the third one is to reduce health disparities in all limited English proficiency communities, regardless of ethnicity or cultural heritage. Our council has been working and supporting this effort because addressing language barriers in healthcare settings and quality interpreting continues to be among the main priorities for at least 200,000 limited English proficiency Latino Minnesotans across the state. Last summer, the council visited 7 towns in greater Minnesota to conduct listening sessions and understand the challenges faced by Latino communities and also opportunities for change. And across these towns, in the area of health, improving the quality of interpretative services was consistently referenced as a high priority for the council to work on. Also, in focus groups conducted in the metro area by the Hispanic Advocacy and Community Empowerment through Research HACER in 2016, members of the Latino community also recommended that medical settings should staff professionally qualified interpreters. As you know, in 2014, MDH consulted with a broad range of interpreting stakeholders and conducted research that gained consensus regarding standards for training and testing, system structure and oversight, the role of an advisory council that my colleague Anjuli mentioned, and management of complaints. Other states like Oregon and Washington already have a similar model which responds to the specific characteristics and demographics of those states. So we believe that this bill will put the state of Minnesota on the same path of reform. As Anjuli also mentioned, an important addition is that the Minnesota legislature will establish an advisory council that will serve as an inclusive forum to address other aspects of the medical interpreting profession with the overall goal of benefiting patients. This bill is in the best interest of the public, patients, providers, and the medical interpreting community, and it accomplishes all of this without taxing the public. We strongly encourage the committee to move this bill forward. Thank you very much.
Thank you, Ms. Tolk, for your testimony this evening. Welcome to the committee. Please state your name for the record and present your testimony.
Thank you, Mr. Chair. My name is Shul Perez. I'm a full-time Spanish medical interpreter at Children's Minnesota and also an adjunct teaching specialist of the healthcare interpreting field at the University of Minnesota. I urge the committee to support passage of House File 2023. Being an interpreter is so much more than just being a bilingual person. Interpreting is a complex, demanding task that requires interpreters to regularly make ethical judgment and decisions. Interpreters need to possess an excellent command of languages, in addition to skills and abilities specific to interpretation and knowledge of the subject matter being interpreted. Interpreters are to skillfully weave in and out of distinct roles, such as message converter, message clarifier, cultural mediator, and on occasions, patient advocate. The current roster of spoken language healthcare interpreters administered by the Minnesota Department of Health has no training or competency requirements for interpreters. Published studies indicate that interpreter errors decrease with increasing training. House File 2023 establishes training and competency standards for spoken language healthcare interpreters and requires that interpreters provide documentation of training and testing they have completed. In addition, it provides financial assistance to assist interpreters in meeting the testing requirements and create a public and private task force to identify long-term sources of money for training and testing. There is also a study to examine linking interpreting reimbursement to level of training and competency that will allow the interpreter to have a higher reimbursement and be an incentive for interpreters to increase their knowledge and improve their skills. Since I began working as an interpreter in Minnesota in September 2009, I have heard time after time stories of frustration from patients and their relatives, as well as from providers who have received poor interpretation services. A few years ago, I personally experienced the apprehension and anxiety that comes from receiving the news of being diagnosed with cancer. And I can't imagine limited English proficiency patients facing a situation like this with the uncertainty that they may not receive the correct information to make a decision which will determine the best possible health outcome. We cannot continue with the status quo. According to the current statute, the roster was just going to be the first step to establish a plan for a registry that was supposed to be developed by 2010. The replacement of the roster with a verified registry is well overdue. I personally know how important it is to have accurate information on health issues. We're talking about potential life or death situations. I wish all of our limited English proficiency patients and their relatives in Minnesota will have the opportunity to have accurate information in medical-related issues that is paramount to health equity. A verified registry is the right foundation towards this end. For this reason, I urge the committee to support the passage of House File 2023. Thank you.
All right, thank you for your testimony. Representative Omar, was there anyone else in your presentation?
No.
All right, then we'll move to questions on the DE1 amendment. Representative Albright, we'll continue with you first.
Thank you. Representative Omar, I'm looking on page 4 of the DE. And understand, for the purpose of my line of questioning, this is really important. And I'm concerned about making sure we get it right the first time, rather than to have to come back and correct the issues that were not overlooked, but not purposefully vetted. So I hope you'll take it in the vein that I've just described. On page 4, lines 4.24 through 4.26, it's referenced about a code of ethics and an interpreting standards of practice. So is that something that this advisory council is going to be preparing? Is it something in existence? Or is it something that you will be accessing, through the Midwest Translators and Interpreters Association?
Representative Omar.
Chair, Representative Albright, I do appreciate the questions. That standard is it already exists, and it's set by the Minnesota Department of Health. And with the training and the examination, this is something that the interpreters would be exposed to, and that's how they will become either registered or certified.
Representative Albright.
Thank you, Mr. Chair. So that's an after-the-fact type of ethics. Page 5, lines 5.8, 5.9, and 5.14. We're talking about the abuse of the relationship between the patient and the interpreter, and the harm that might come to the patient by way of deception, fraud, harm. My question is, what is the mechanism by which you will know that that has occurred?
Representative Omar.
Chair, Representative Albright, there is a process put in place where the patient can contact the Department of Health to file a complaint.
Mr. Chair.
Representative Albright.
Thank you, Mr. Chair.
That's my understanding, at least.
Representative Omar, but you understand that the patient is relying upon the interpreter for a translation from a physician to their spoken language. And so they are at ultimate and infinite trust for the interpretation of the language spoken by the provider into the tongue of the patient. How will they know that they are not being deceived?
Representative Omar.
Chair, Representative Albright. Currently, there are no protections, there are no mechanisms. This bill attempts to put some of those protections in place.
Representative Albright.
Thank you, Mr. Chair. The continuing education that you cite on page 7, section 5, in the DE, 3 hours per year on a registry basis. Do you have courses that are already, or do the stakeholders already have courses that are approved that would be vetted by the advisory council, or is that something that the advisory council is going to take up exclusively to their supervision? Or is there any consultation with other groups in terms of the CE credits that would be appropriate for the various tongues that and spoken languages that would be applicable to this amendment?
Representative Omar.
Chair, Representative Albright, that is in the preview of the advisory council. It is a public and private partnership, and the Department of Health and the members who are both practitioners and patients would be able to advise.
Representative Albright.
Thank you, Mr. Chair. Maybe just a couple more questions. On the last page of the DE, the 11, they talk about a stratified medical reimbursement system. I understand, and I'm hoping you'll avail me some latitude on the questions. Is this something that is in the works that will be presented to finance, or is this something that is part of the advisory committee only? We talk about the current medical MA reimbursement rates. We know those. But you talk about a stratification. Is that something that the stakeholders have undertaken in terms of agreement to, or is this part of the advisory council only?
Representative Omar.
Chair, Representative Albright, this again is something that's currently not in place that we are trying to establish. And so that is the point of this bill, is to put in all of these processes in place that currently do not exist. And so that's with the help of the Department of Health and the Advisory Council, it is something that they'd be able to do.
Representative Albright.
Thank you, Mr. Chair. Representative Omar, on the back page, the repealer notes repeal of 144.058, effective July 1, 2020. That effectively removes the opportunity to consult with Midwest Translators and Interpreters Association. Is there some reason why you would not want to associate or matriculate your work with that association?
Representative Omar.
Chair, Representative Albright, the establishment of the advisory council would allow those stakeholders to have a permanent place. And so by repealing it, it doesn't mean that we are no longer having them have a voice at the table, but we are giving them a voice at the table along with others.
Representative Albright.
No more other questions.
Representative Sandsted.
Thank you, Mr. Chair. Representative Omar, just a little bit of clarification, if you can, on the registered interpreter versus the certified interpreter. I see what is required hours-wise under the registered category. Tell me a little bit more about what it would take to become certified. Is one level of certification higher than the other? And then the second part of that question would be, how would those be used, in what setting? Where would one be used over another, or are they interchangeable?
Representative Omar.
Chair and Representative, for the registered, this is guidelines that we are setting. And for the certified, there are already guidelines in place because there is already a certified certification that happens nationally. And the settings are exactly the same.
Representative Sandsted.
Sorry to dig a little deeper, Representative Omar, the rigor between these two, are they similar? Is it more rigorous to become certified than registered? And again, you said they could be used interchangeably?
I'll have the testifier give a little bit more clarity on what is required to become certified, since those standards already exist. But my understanding is that to become registered, that's an entry level, and to become certified is more of a second level. But
Mr. Perez.
Yeah, thank you, Mr. Chair. Yes, I am a certified Spanish medical interpreter by the National Board. There are actually 2 national board certifications, actually, and I am part of one of those. In this case, like Representative Omar was saying, the purpose of the registered interpreter is just to pass a basic medical terminology. So basically, it is a lower status or lower level that the certified interpreter, and there will be also an exam on the ethics and standards of practice. Those ethics and standards of practice are something that they are really established. That was established about 10 years ago. So, and that was a national established, and there are actually 3 different associations. 2 of those are national associations that they have established the interpreter ethics and standards of practice, and basically the Minnesota Department of Health, with the advice of the advisory council, they're going to try to put up a basic test so that all of the interpreters that are right now currently on the roster will be able to have all that information free of them available to be able just to study and be able to pass this test, and that will be to have at least the minimum basic requirements. Obviously, for the national certification, that they will have to go to the national boards and pay all those fees to be able to pass those tests.
Representative Sandsted.
Thank you for that. And then my final question would be, if I needed an interpreter and a healthcare facility reached out or contacted the registry, is preference given to a certified translator or interpreter over a registered, or is it first come, first serve?
Representative Omar.
Chair, Representative, it should be first come, first serve.
All right, Representative Peterson.
Thank you, Mr. Chair and Representative Omar. Thank you. This is no small lift. My understanding is this is relatively new to the country, unless you can share with me what other states have done. I mean, my understanding that Oregon has something, but although this is different than what they've done there. So if you could just maybe expand on that, please.
Mr. Perez?
Yes, Mr. Chair. My understanding is that, yes, in Oregon, it's in some way similar to the one that we have here. They have also 2 different levels to be either qualified or certified interpreter. So in that sense, there is a registry there. My understanding is that there is also a registry in California, but I don't have right now all the facts to tell you about that.
Representative Peterson.
Thank you, Mr. Chair. And so I just, that's why we're all so very interested in this work, because we want to make sure we get it right. So thank you.
Thank you, Representative Peterson. Representative Liebling.
Thank you, Mr. Chair. Representative Omar, I really appreciate your working on this. This is, members, you probably remember, this is an issue that we've been trying to get this thing right for a really long time. And when we engage in regulating an industry, the real key question always is there a public safety issue? What is the public's interest in this? And this is one where the public interest is enormous. In this committee, and in the HHS Finance Committee, we're always talking about how much money we're spending, trying to deliver the right healthcare services. Well, if the patient does not understand the healthcare provider and vice versa, it's really hard to do good work in that area, and money can be wasted, and worse, as the testifiers described, you can get really bad outcomes just from lack of understanding. So what we have right now is completely inadequate. Anybody can be an interpreter, I think just still by paying $50 and being on the registry. And they don't necessarily understand the ethics of interpreting or have the real understanding of the languages as the folks were talking about. To the ethics piece, just imagine if you don't understand as an interpreter that your job is to tell the patient what the doctor said and vice versa, and you think that you're going to put your spin on it, or sometimes we hear about children who are interpreting for their parents, and they might think mom doesn't really want to hear this thing, so maybe I'm not really going to tell mom she has cancer. Those kind of things can happen. So that's what interpreting ethics are about. It's really important to understand how to conduct yourself in that space. And it's not something anybody can do. And we have the part of the problem of licensing or regulating in this area is that we have this incredibly broad range of languages and cultures involved. And that's the problem we run into in the past when we've tried to do something like this. So if Representative Omar has gotten all of the stakeholders to a place where people are pretty happy with it, we should just grab it while we can. And if we need to make adjustments to it in the future, we'll make them, just like we do with everything else. But it's a real safety issue. It's a real important healthcare issue. And it looks to me like it's a pretty good, it's gotten really worked on a lot over a number of years. And I sure hope we can do this, because we just really, I don't see how we really go on trying to provide healthcare with so many people who need at least some help with the language. And just to say, too, people sometimes who have otherwise very good English skills, when they're ill, they may not understand quite as well, and they need it in their native language, even though they may otherwise get by pretty well in English. So this is really a big issue, and I just really commend Representative Omar, because I know, as Representative Peterson said, this is a big lift, and others have tried and failed. So I hope that we can move forward with this and get it done this year. Thank you.
Thank you, Representative Liebling. Representative Gruenhagen.
Well, thank you, Mr. Chair. Yeah, my understanding is there's some individuals here with concerns about the bill, and I think I'll hold any questions or comments until I hear from that side.
Okay, thank you, Representative Gruenhagen. Yes, we haven't opened up public testimony yet on the bill. That is my intention after we get through members' questions on the DE1. Representative Munson.
Hi, thank you, Mr. Chair. And I hope this hasn't already been asked, but I actually I lived in a foreign country and did not, even though I thought I was fluent in the language, found out I wasn't fluent in medical terminology, so I ran into quite some surprises when I went to seek medical care. So I understand how important having an interpreter is. I guess my concern is that it appears to already be a national registry for interpreters. Is that what I'm understanding, that they have a national certification, and that Minnesota is now creating its own unique certification, and with additional licensing or additional licensing in a registry and fees on top of that, and it seems to me that where we have so many people moving in and out of the state, that it would be, it would create an extra level of difficulty for interpreters to register in the state or try to figure out where they're supposed to register, and I just want to make sure that I'm clear that there already exists a registry system nationwide and there's a certification, that this is creating a second level of certification?
Representative Omar.
Chair Representative, no.
There's not.
Representative Munson.
Okay, so, okay, that's good to know. Thank you.
Representative Halverson.
Thank you, Mr. Chair, and I'll second what Representative Munson said about medical terminology. I went to nursing school, and we had a whole class on medical terminology, and to this day, I still write in medical shorthand, so woe to my assistant, who, all my assistants have to learn medical shorthand, because I write in it still. It's very convenient, but it's not easy to understand. And medical terminology is not easy to understand and interpret as well. And so the clarity is a very important point. I did want to address Representative Albright's questions regarding the repealer, because I think repealers, it's really important to understand the repealers in law when we see these, and we don't always get to see the language. So it looks to me, and perhaps our researchers can see if I'm interpreting this correctly, that what is being repealed is the law that got passed in 2008, that all the work has been completed. So what the direction was at the time to the commissioner was to establish a roster and a plan of standards for registration, and that they were to consult the stakeholder groups that Representative Albright mentioned, but that work is all complete. What I see now is a new advisory group that does have seats for the stakeholders to have seats on this new advisory group that will be doing much more than establishing a registry, but establishing policies around ethics and standards for interpreters, et cetera. So I think that that's the way I understand it. So nothing's being taken away. That work was completed in 2010, from what I understand. If maybe Ms. Clark-Quist can.
Ms. Clark-Quist.
Mr. Chair and members, I think that's an accurate description of the section that's being repealed.
All right, thank you, Representative Halverson.
It's always a good thing when we can practice that.
Very good, Representative Halverson. Thank you very much. Representative Albright, did you want to ask your questions now or after the testifier? Okay. Before we get to that, I do have an oral amendment on page 10, lines 22 and 25. Page 10, lines 22 and 25. After the word care, we need to insert the word interpreter. Page 10, lines 22 and 25. After care, insert interpreter. And I will make the motion that on page 10, lines 22 and 25, after the word care, we insert the word interpreter. Are there any questions on the oral amendment? Seeing none, all those in favor of the oral amendment signify by saying aye. Aye. Opposed, same sign. The amendment is adopted. All right, I think we'll open it up to public testimony now. Is there anyone who wishes to testify on House File 2023? We still are on the DE amendment. If you could please make your way forward. Welcome to the committee. If you could please state your name and present your testimony.
Thank you, Chair Schomacker. I appreciate the opportunity to testify. My name is Michelle Levon, and I am the owner of Multilingual Word, Inc., a company which has provided spoken language healthcare interpreter services throughout Minnesota since 1995. I am here today on behalf of the IAM, Interpreter Agencies of Minnesota. We are the trade association that represents interpreter agencies that provide interpreter services for tens of thousands of healthcare visits in Minnesota each year. IAM has been an active stakeholder in discussions regarding proposed interpreter legislation since its inception, and I have also been an active member of ISG, the Interpreting Stakeholder Group. As a past member of the ISG Training Committee, I am a strong proponent of quality in the field of interpreting. Over the course of the last several years, bills such as this one have been proposed as a top-down approach to improvement of the interpreter pool, but rarely have active freelance interpreters themselves been involved in the process. We were unfortunately not aware that the bill was being heard until late last week and were not consulted on this delete everything amendment. even though we were involved in last year's discussions on the Senate side. I might also note that even without legislation, the market itself has already called for the improvement of the quality of the pool of interpreters over the past several years. Many of the healthcare providers we contract with already require interpreters to have taken a 40-hour training in order to be allowed at their facilities, while making exceptions for the less common languages. As a result, a vast majority of the common language interpreters have already complied with this requirement. These improvements have been made even as payments for interpreter services have been cut. After quickly reading this delete everything amendment, we realized that some of our suggested changes from the Senate version from last year have been included, and we appreciate that. However, we still feel that we need additional time to review the specifics and provide direct one-on-one feedback to the author of the bill. After a quick review, we have identified 4 concerns with the bill as presented. Number 1, the eventual increase in fees to $70 and then to $90 for interpreters to join the registry starting in July of 2020, compared to the initial fee of $50 in accordance with the current Minnesota roster fee, will place a financial strain on interpreters and could have the unintended consequence of reducing the pool of interpreters, specifically for rare language interpreters who may only have a few assignments per year. We would like the opportunity to discuss the fee structure further. Number 2, the bill in its current state gives the commissioner the power to make sweeping changes with little or no oversight, as exemplified in Section 4, Subdivision 1.4. Number 3, we want to be sure that Minnesota interpreters are not disadvantaged and that the same education and quality standards will apply to non-Minnesota interpreters providing remote telephonic and video interpreter services to Minnesota patients, as will apply to face-to-face interpreters working on-site in Minnesota, and that the legislation is carefully worded so that a massive loophole does not exist. And number 4, we want to make sure that too high of a bar through legislation does not cause even more interpreters to exit the field and diminish limited English proficiency access to qualified interpreters, particularly for those that speak the less common languages. We would appreciate the opportunity to work with Representative Omar and the other authors to alleviate these concerns before the bill moves on to the next committee. Thank you, Mr. Chairman.
All right, thank you, Ms. Levon, for your testimony this evening. Are there any questions for the testifier? Representative Dean.
Thank you, Mr. Chair. I just have a couple just questions about how you do your job. One of the things that I was wondering about was you had touched on it just briefly in trying to tighten it with the proposed legislation. And that is with telehealth or non-face-to-face interpreter services, and services sometimes over the phone. How is that handled right now in statute, and how do you get paid for it?
So my company doesn't actually provide those services. Many are provided from out-of-state companies, but we want to make sure that the interpreters that are in Minnesota are not competing with interpreters from other states that have lesser qualifications or lesser requirements imposed on them.
Sure. And just, it looks like there's a national, I'm looking at the MDH's website, there's a National Board of Certification for Medical Interpreters that you can receive training and certification through. And then the second one was, I think you said for less common languages, there's a secondary certification. Is that accurate or is that not accurate?
So not quite. Most of the lesser common languages do not have tests for certification at all.
Okay.
So they're not having that option even.
Okay.
Sure, Dean.
So the idea would be that there's only a very small percentage of people that would come up. You wouldn't develop a whole curriculum and testing just around that one very, very rare language. Is that correct?
Correct, yeah.
Ms. Levon.
There's a It's not really a certification, but there is an entry point into certification by taking a test in English for some of the less common languages.
Okay. And just finally, if somebody were to want to become an interpreter, about how much money would it take to get the training that you need to become certified or licensed so that you can get paid for what you do?
So that will vary. There are a couple of 40-hour training courses that are available, and they pretty much start at $500. Depending on where you take it, it can go up. I've seen it advertised for closer to $700 in other states. I think many of the companies such as ours kind of subsidize those prices to make sure that it's accessible. And then there is the University of Minnesota Program in Interpreting and Century College.
And just finally, are any of your employees or any of the people that do this unionized in Minnesota, and under what union?
Ms. Levon.
So we work with independent contractors, so there is no union. But I am aware that Hennepin County Medical Center has their interpreters as part of a union.
Thank you.
Thank you, Chair Dean. Representative Munson.
Thank you, Mr. Chair. So again, I went online to find the International Medical Interpreters Association and the National Board of Certified Medical Interpreters. There's two different websites that have training and registration. 220 certified interpreters on one site listed in Minnesota. So I'm a little confused on why we're creating another layer. But I also wanted to just ask, and I noticed we keep on referring to spoken language. Why isn't sign language included in this registry? And have you spoken to the sign language group, and why are they not on board?
I believe that sign language has their own certifications and their own requirements already in place for many years. So the foreign or spoken language interpreters are kind of coming up to the level of where sign language has already been.
Okay.
Representative Munson.
And is the sign language interpreters, are they also regulated and pay fees to the government, or are they self-certified privately like these other organizations?
And I'm not an expert on sign language. That industry is a little bit different, but I believe that they take a certification through a national group, and that they are certified in that way, but I don't believe there's any government agency.
Okay, thank
Representative
you.
Munson.
Thank you.
Representative Gruenhagen, did you want your questions now?
I'll pass. The discussion kind of answered most of them.
Very good. Seeing no other questions, Ms. Levon, the committee thanks you for your testimony this evening. Is there anyone else who wishes to testify on House File 2023? Welcome to the committee. Please state your name for the record and present your testimony.
My name is Ili Yu. Actually, I'm an interpreter myself, too. I have no objection to improve interpreter quality or to let interpreter get the training. That's good. That's a good thing. But I know on this bill, I see there's still a lot of specific questions behind the training. Of course, is good, but there are a lot of specific problems involved that need to be addressed before the bill can be passed, whatever. No, I just see this sign say, here said that if an interpreter participate in study can increase wages. I'm wondering who will do the increase. Usually, I think for the interpreting reimbursement given by MA state insurance, only MA Minnesota Care pay for interpreter fee, usually through interpreter agency, whatever. So that's a kind of the whole big category. So I don't know whether it's can be based on the individual interpreter performances. almost all interpreters are contracted interpreter because interpret agencies only give interpreted 1099. We never get the W-2 thing. So we're not like employees. So yeah, so that I think probably only those hospitals they hire an interpreter as their employee. So for this increase wages, so I don't know who will do the increase in wages for interpreter. Yeah, I think I see the renewal process or whatever. I think that's kind of a little bit too much burden for interpreter. On one hand, said the commissioner need to notify interpreter like 2 months ahead of time, but the interpreter need to do the review 1 month before this 1 year registry expired. So, and that's what if register in 1 year. The only 12 months, so deduct this 1 month or 2 months. So, I mean, how can interpreter keep up this date, whatever, and then say if late, then if the late fee, whatever, and then even late, then need to reapply, whatever. That's too much hassle. Yeah, and now for. Seems that right now the previous bill seems that healthcare costs are rising, so it seems interpreter reimbursement are keep cutting down. I know for probably the doctor nurses salary probably cannot, no one there to cut their wages, but the interpreter seems the payment. Cutting down and down. I think 10 years ago, 12 years ago, probably one interpreter appointment would be $50, probably, and then like 10 years ago or 9 years ago would be $40 for one appointment. That's for interpreter get it. I know usually interpreter agency will take some payment from the middle, but right now the interpreter payment only like $35 per one appointment, kind of within 2 hours, 35 or even 30. Yeah, so the reimbursement getting down and down. But I see there's some, maybe there's some financial assistance to help with the training. I know that'll be good. But also, I see for the discipline of the interpreter, whatever, I think this need to be talked in the both ways. Of course, even for unprofessional interpreter, there should be discipline. But on the other hand, interpreter, a lot of time can be get wrong too. So there should be way for interpreter has a right to appeal, something like that. Actually, for me, I've been working as the interpreter for 14 years in Minnesota. For interpreter, I think there's a one chance is that for the interpreter can observe different clinical practice, so they see sometimes interpreter are maybe the best observer for each clinic. So which clinic are the better, which are the less good. Yeah, they can like a third person. They can see the probably more objective. They can just see different clinic the practice way. So sometimes when interpreter maybe when they see some provider may not be so conscientious, whatever. If they point out that sometimes the clinic may not happy, they kind of may take a revenge on the interpreter. Yeah, so for the discipline, sometimes we have to look at the both ways. So the interpreter should have some right for appeal, whatever. Yeah. So Okay.
All right, thank you very much for your testimony this evening. Is there anyone else who wishes to testify in House File 2023? Please make your way forward. Welcome to the committee. If you could please state your name and briefly give your testimony.
My name is Zoe Z. I'm the Chinese Community Board member at Council on Asian Pacific Minnesotans. I understand that the council staff has testified to support this bill. As far as I know, the council, at least the board members, have not discussed it in deep discussion about this topic, and no consensus has been reached. So I think it deserves a benefit of doubt when a council staff or council staff represent that they're representing all 500,000 people in Asian Pacific community. I come here to raise concerns about this bill because let's not forget the ultimate goal of this bill is to serve the vulnerable immigrant community. And as Minnesota becomes more diverse and there are more and more immigrant communities coming, immigrants coming into the community, and there's among the 40 Asian Pacific Minnesotans, you know, only a few that's well-established communities. Lots of them very new, and or even if they've been here a long time, they still don't have enough interpreters, especially in rural areas. So with the entry level, with the entry bar raised so high, and as Ms. Lee testified, the interpreters not getting paid like $100 an hour, but they have to take the test, go through the training, and also do annual renewal, which is really very restrictive because I understand the real estate license takes 2 years to renew, insurance license 3-year renewal, teacher license 5-year renewal. And then for interpreters, get paid minimum wage most of the time. They have to renew every year. And that's really, to me, is very outrageous. I think, you know, they're not doctors and lawyers. Anyways, so that really limits the access for patients. And I know that the Chinese community seniors have very difficult time making appointments, not because the doctor's not available, because the interpreters are not available. So that really delayed the access to medical care. In some cases, they're urgent. You know, they want to be seen right away, but you know, even the doctor's available, the interpreter's not available. And in some cases, the interpreters are overbooked, and they can't be on time for a procedure like a colonoscopy when the patient has been preparing for 3 days, fasting, not eating, and it's a terrible time went through. And by the time they went to the doctor's office, say, sorry, the interpreter, you know, somehow could not make it today. So they had to go back and take all these prep work, another 3 days to come back. And it happened. I mean, it's a real story, and it's close to me. So things like that happens, and I'm really concerned about this bill will raise a bar for some communities, especially the most vulnerable immigrants that, and also there, I think the people talk about remote or telephone interpretation for seniors who has hearing problems. It's real problem because they can't hear on the phone. Even, you know, you have to be right in front of their face and talk to them. Maybe they will understand you, and then by watching your mouth, how the mouth moves. So that's another problem with all these things. So I just have serious concerns about it, and I think I voiced to the council, but haven't been taken notice. But I'm glad I heard it today from a Facebook message that there is a hearing today here in the evening. So I made it here. I didn't prepare anything, but I hope my message can get through. I hope all the legislators will take this matter seriously, because there are some seniors, vulnerable seniors who doesn't speak English, may need urgent Medicare just because the interpreter does not have certification. Therefore, they never be seen by the doctor. And it could happen anywhere in Minnesota, and not only metro, but also in rural areas, just because they don't have a qualified or certified interpreter. Thank you very much for this opportunity. Thank you.
Thank you, Ms. Z. Representative Munson.
Hi, Mr. Chair, thank you. I have a question for the testifier before she leaves.
Ms. Z.
Yeah.
Representative Munson.
Hi, thank you for your
Okay.
testimony. I do have a question outside of, I guess it's a different subject, but have you used the Google earbuds that translate real time and have been shown to use to translate medical terminology? Has anybody implemented technology for translation instead of having a person?
Ms. Z.
I personally, I have no experience like that, but I see some people use Google Translation, and it seems like when I talk to my clients and they can't speak English, and they can do the translation well. Yeah, and I think that may help. I'm thinking about some seniors may not hear, maybe they can use some device that can interpret well, maybe instead. For the phone conversation, it's really hard.
Representative Munson.
Okay. Yeah, I think it's really important to address the technology that seems to be pretty cutting edge and available to translate real time from, I think, 46 different languages that it works today. But I'd be interested in hearing somebody's perspective if they know more. Thank you.
All right, thank you, Representative Munson. Is there anyone else who wishes to testify? If you could please make your way forward. If you're planning to testify, we'd like to be able to manage this. Welcome to the committee. Please state your name for the record and present your testimony.
Mr. Chair and members of the committee, for the record, my name is Sia Her, and I am the Executive Director of the State Council on Asian Pacific Minnesotans. Ms. Z, who just spoke prior to my presence here at this table, made a comment that is very much to my surprise, so this committee is not the place to hash out the drama of the Asian Council, but I want to make it really crystal clear to this committee that the Council on Asian Pacific Minnesotans stands in full support of this bill. To make a long story short, the bill was brought to the attention of our council several years ago, and Senator Her, who happened to be a legislative member at the time, came to the staff and asked the staff to look into whether or not this bill would inhibit members of the community from participating as interpreters, meaning that he wanted to know if there would be negative unintended consequences. The staff took it upon ourselves to do the necessary research, and we came back to the board, including Senator Hurd, and advised the board to support this bill. So I want to put that on the table in front of you so that it's available for the record, and then that's my sole objective for coming before you here tonight.
All right, thank you for your testimony. With that, we will close public testimony and move to member questions. Representative Liebling.
So thank you, Mr. Chair. And we get a flavor tonight again of how difficult this bill is. And yet it's so important.
You spoke too soon.
I know I did. I probably jinxed you, Representative Omar. I'm sorry. But Mr. Chair, I really wanted to ask you, what stops does this bill have? Or maybe Representative Omar would know that, because obviously there's still a little more work to do, and that doesn't mean that it can't be fixed and that we can't, tweak it a little more and still get it done.
Representative Liebling, it looks like the next step is government operations and then civil law. And I believe government operations has it on the calendar for tomorrow?
Yes.
Okay.
Okay, thank you.
Yeah.
Right, thank you, Mr. Chair. And so it's got at least a couple more stops. And some of the things that have been, this is the Health Committee. And so a lot of the issues are also issues that really are not health issues that are connected to this, because of course, it impacts people's livelihoods, and, there are just a lot of issues connected to this, and that's why it's been so many years in the making. But, I still think that, it's a great effort, and I am very hopeful that we can move forward with it. And I know Representative Omar is very good at bringing people together and trying to work out solutions, and, I'm very hopeful that we can move forward with something this year. So thank you again.
Thank you, Representative Liebling. And Representative Tice.
Thank you, Mr. Chair.
And Representative Omar, I just have a few concerns on the renewal part of it in Section 3. When we're talking about the notice, and some of this just doesn't flow very nice. And so maybe we should look at some of the other, I guess, how some of the other renewal notices are out. You know, that says 60 days before the registry, everything's going out, but then it has to be submitted 30 days before. And then the late fee talks about the renewal deadline must include a late fee. And I think that's really awkward and burdensome.
Mr. Perez.
See, right now, with the current statute, they send you the kind of the reminder 60 days before, and then you have until the renewal date to do it. So that is
Representative
what it is right now.
Thank you, Mr. Chair, and Representative Omar and Mr. Perez. The only reason I'm saying that is I was in the building industry for quite a few years, and we didn't have a recommendation that we have it postmarked at least 30 calendar days beforehand. That just sounds like to me, it's looking for trouble. So my concern is maybe you want to check that out a little bit more and see if that is something that we can look at a little bit better. I don't like it, and I don't want people to miss the deadline because of the 30 days beforehand. I just think that's awkward. If it's due on, whatever day, that should be the day you need to have it in, not 30 days before. I just think it's looking for trouble. So I just want to raise a flag to you and say maybe you want to talk about that one a little bit more, look into it so that when it comes time for renewals, we get renewals and folks aren't expected to send it in with a late fee.
Chair Representative Tice, thank you for your input. That actually makes sense.
Thanks.
Thank you, Representative Tice. Representative Albright.
Thank you, Mr. Chair. I won't reiterate what has already been said. I think, and I really appreciate the comments that have been said, particularly Representative Halverson and Representative Liebling. This is a big lift. And it's very important for a couple of reasons. One is because we are dealing with what would be purported as some very vulnerable individuals. It is compounded by the fact that they are in an immigrant community that have a disadvantage of not speaking English as their first language. Now you layer on top of that the cultural mores of how you treat illness and or how you treat illness from their perspective as opposed to modern or Western type of medical processes. And you add on that they're getting interpretation from one of their own kin, if you will, and you have to flavor in and blend in the ethics of how they respect and or communicate with their elders versus their younger subordinates. Now add to that what Representative Liebling said is we have an issue of public safety. But before we go to the issue of public safety, we have to endear ourselves to the trust of the public. If we don't have trust, then are we really providing the safety net for these people as well? So I'm on this bill as a co-author. It's a very, very important process that we're undertaking for not only the people that are here, but for the people who are coming here. We have to get this right. We have to get it right for the people that are in need of the services that this type of policy will provide. But it's also important that we don't put the people who are providing the services in a catch-22 in terms of their want of providing services, but yet they have to be encumbered with either the regulatory or the fee or the insinuation that they're not interpreting correctly. I don't know that any policy in statute will rectify any or all of those concerns that I've just raised. But this is a piece of legislation that with a DE, I don't believe, as a co-author, is ready for prime time. And I would implore the author and the stakeholders to spend the amount of time necessary to consider their alternatives and/or adjustments to the bill as it makes its way forward, in consideration of whether or not half a bill is as good as taking your time and making it a whole. So, thank you for the conversation.
Any other questions for the bill author? Seeing none with that, I will renew my motion that I will move the DE1 amendment as amended. All those in favor signify by saying aye. Aye. Opposed, same sign.
Aye.
The DE1 amendment as amended is adopted. Representative Omar, final word on your bill.
I just really appreciate the opportunity to have this conversation. I want to make some few things clear, I guess. One is that the registration isn't mandatory, and I think our job is to, like Representative Albright said, our job is to protect the most vulnerable members of our society, and we are talking about having an adequate access to health care, and we want to make sure that the people who are between the patient and the doctor have the ability to be able to be to be able to provide that care as well to that patient. And so this is a further attempt for us to come to a solution that is, one, going to take care of the patients and hopefully bring everyone along. I'm looking forward to working with Representative Albright and others in getting the bill into a shape that works for all of us before it goes to the other committees on Thursday and onward. So with that, I hope you all will support this bill and help us get closer to making sure that patients are getting proper care that most of us are used to, and making sure that we give others what we expect ourselves.
With that, I'll renew my motion that House File 2023 as amended be re-referred to the Committee on Government Operations and Elections Policy. All those in favor signify by saying aye. Aye. Opposed, same sign.
Aye.
The motion prevails, and House File 2023 as amended is re-referred to the Committee on Government Operations and Elections Policy. That concludes our agenda for this evening. We will meet again Thursday, March 29th at 8:15 in this room. We'll see you then.